Good evening, respected faculties. I'm Bhavna from Corona Remedies. I welcome you all for our webinar with AMOGS Medical Disorder Committee with Nizambad, Nalgonda, Karimnagar, Mehboob Nagar Society. I welcome our chief guest, Dr. P.K. Shah, Dr. Shyam Desai, our guest of honor, Dr. Jamuna Devi, AMOGS President Secretary and ICOG Chair Secretary, Chairperson, Dr. Sneha Bhuyer Ma'am, coordinators Dr. Lakshmi and Dr. Charu, and MOC Dr. Suman Sinha. I welcome all our esteemed faculties for the lamp lighting session. Sorry, ma'am, just a minute.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now I welcome our MOC, Dr. Suman Sinha, President Ranchi Obesity Society. Dr. Suman Sinha is Senior Consultant at AHIVF and Infertility Center Ranchi. She is Director of Advanced Care and Maternity Center Ranchi, Vice President, Society of Vaginal Surgeons of India, Bihar and Jharkhand, and many such feathers associated with her. Her specialty is vaginal surgery, high-risk pregnancy, and endoscopic surgery. Suman ma'am, please welcome.
Thank you, Bhavna, for your very kind and lucid introduction. Good evening, everybody. Lamp lighting by our dignitaries has given a divine touch to the webinar, and topic of today's webinar has been very aptly selected because today is the World Hypertension Day. I, Dr. Suman Sinha, now welcome all the dignitaries and esteemed guests for the webinar organized by AMOGS in association with Nizambad, Nalgonda, Karimnagar, and Mehboob Nagar OB/GYN societies. I welcome our chief guest, Dr. Shyam Desai sir, and Dr. P.K. Shah sir. I also welcome our guest of honor, Dr. Jamuna Devi madam, all the speakers, chairpersons, moderators, panelists, for very meticulously preparing the subject to enlighten us in the recent advances in the obstetric and gynec field. I also welcome the beautiful co-coordinators, Dr. Charulata Bapai and Dr. Lakshmi Charumila, and all the participants who have logged in, and also to the academic partner from Corona for giving us this platform and supporting us. Now I take the humble opportunity to welcome and introduce Dr. Sneha Bhuyer madam, who is the director of today's webinar. Can I have Madam CV? Yeah. Madam is presently AMOGS Chairperson Medical Disorder Committee. She is the founder president of Vidarbha ISOPAR. She is also SAFOG Working Committee member on breastfeeding. Presently, she is Governing Council member of ICOG, and she has been the dynamic chairperson of Breast Committee of FOXI between the year 1919 to 2021. And she is recipient of International MS Signature Award for Phenomenal Leadership. And she has received the S.N. Malhotra Individual National Award, Dr. Dhruv Shah Distinguished Community Award, Dr. Anandibai Joshi State Award, by Government of Maharashtra. Look,
Thank you.
Healthcare Excellence Award
Thank you so much.
2020, and she has a huge experience of 30 years in obstetric and gynec field and has given more than 300 talks and presented more than 400 publications in index journals. So welcome, Dr. Sneha Bihar.
Yeah,
I request you for the official address.
yeah, you can stop sharing, Bhavna. Thank you so much, Dr. Suman, for that kind and generous introduction. I would say it's not 400 publication, my dear, it's only 30 publications. A very good evening to respected chief guest for today's program, Dr. P.K. Shah sir, Dr. Shyam Desai sir, Dr. Jamuna Devi madam, and AMOGS President Dr. Rajendra Singh Pardesi and Dr. Sujata Dalvi madam, who is the secretary. I'm so happy to have all my mentors on one platform today. Dr. Sujata Dalvi is not present because of a close relative is getting operated for COD, and I welcome all of you here. I welcome all the esteemed faculties for today's program, the panelist chairperson. I also want to acknowledge all the president and secretaries of the Nizambad, Nalgonda, Karimnagar, and Mehboob Nagar societies. I would just like to say their names: Dr. Sujata Bandari, Dr. Vijay Lakshmi, Dr. Manju Rapolu, Dr. Radha Koluri, Dr. Punam Chandramati, who is also a faculty here, Dr. Sunita, Dr. Sucharita, and Dr. Bhanushree Lakshmi. So once again, I welcome all of you here. And thank you so much for your gracious presence. It's my proud privilege to introduce Dr. P.K. Shah sir, who is my mentor. Though Bhavna, you can just display the CV. I would just like to introduce sir as my mentor, who has guiding me in Foxy and everywhere, I would say, right from the beginning of my journey. And sir is the one at the hands of whom I have received my first individual national award way back in 2008. And since then, he's constantly guiding me, mentoring me. As you can see, sir has headed almost each and every organization, and all of you know him as past president of Foxy and past dean of ICMU, and also the past president of Indian Federation of Ultrasound in Medicine and Biology. So lots and lots of post as well as achievement by sir, very, very inspiring. And without wasting much time in reading your CV, sir, we would like to listen to your precious words, sir. Over to you for your precious words and guidance, sir.
Thank you, Sneha. First of all, I must congratulate you for doing excellent work in AMOGS as chairperson of Medical Disorders Committee. I thank office bearers of AMOGS, Dr. Rajendra Singh Pardesi and Dr. Sujata Dalvi for inviting me to be the chief guest, along with Dr. Shyam Desai, who is my classmate, as a chief guest. Also, so nice to chair this platform with Dr. Jamuna Devi, who is a guest of honor. The topic that is taken up is something which affects all of us in practice: hyperglycemia in pregnancy. And it is going to be covered with screening, management, and role of fetal medicine in hyperglycemia in pregnancy. And Dr. P.K. Saxena, Dr. Sushila Rani, and Dr. Chinmay Ratha, they are going to deliver talk on these 6 subjects respectively. And after that, Sneha is going to moderate a panel discussion on case-based HIP cases. It is so nice that even after the actual conferences have started all over in India, we get fantastic webinars. And it's an opportunity for all those who have joined to know everything within an hour and a half or 2, so that you don't have to spend any time trying to learn the subject. I'm very thankful to Sneha that she is involving me in all those subjects where I have deep interest. And it's so nice to see convener Dr. Chinmay Ratha, and the coordinators Lakshmi and Dr. Charu, with Master of Ceremony Dr. Suman Sinha, a very senior person who looked after us at Ranchi. I wish you all the very best, not only for this event, but also for all the events that you have in future. And I also wish you all the very best for all your future elections. Thank you very much for having me. Thank you so much.
Thank you so much, sir. Thank you so much, sir. Can we have Dr. Shyam Desai sir's CV? With the blessings of Dr. P.K. Shah, sir, we'd like to introduce first Dr. Shyam Desai, sir. Everyone knows him as past President Foxy, and I would like to congratulate on this platform, sir, as the President-elect who is going to be installed soon in September as the President of SAFOC. And sir is still the senior consultant in the at Mumbai, and of course past president of Mumbai Obs-Gynae Society, past president of Indian Association of Gynec Endoscopy, and vice chairman of ICOG in 2006. So many awards and accolades to his credit, and sir is such a humble human being, very helping, what I have experienced in person. So we would like to have your blessings, sir, and your words of guidance. Over to you, sir.
Thank you, Dr. Sneha Bhuyar. Can you see my picture? Am I visible?
Yeah.
Yes, sir.
Okay.
Bhavna, you can start.
All right. Okay. Now, thank you, Dr. Suman Sinha, for that introduction. Nice to see you again. Dr. Sneha Bhuyar, Dr. Rajendra Singh Pardesi. There's so many friends that I can see on this webinar today. I'd like to congratulate Dr. Bhuyar for having chosen a topic which is of utmost importance in India, because we are supposed to be the diabetes capital of the world. And very often we suddenly find a patient who's pregnant, has a blood sugar which is out of range. And if we are not able to identify these patients with hyperglycemia and pregnancy, we can have very disastrous neonatal outcomes. Now, the DIPSI, that is the test that is carried out to detect diabetes in pregnancy, is a simple test. I'm sure it will be elaborated upon in this webinar. But you give 75 grams glucose and do a post 2 hour subsequently do the blood sugar. And if it is more than 140, then obviously this patient has to be treated accordingly. Now, we find that many of these diabetic patients also put on a lot of extra weight during pregnancy. And we find that the entire course of pregnancy can also be very distorted. Now, I'm sure all the points will be brought out by an elite group of discussants today. And I'm sure at the end of it, we will all be wiser, and the entire audience will be able to take home many points. I congratulate you for having started this particular series, and I wish you all the very best.
Thank you so much, sir. Thank you so much for your blessings. Dr. Jamuna Devi, madam, she's having some technical difficulties in joining. I would request Dr. Aruna to please coordinate with her. Madam has just called me. So please coordinate with her. She wants a link on her bill. So if you can please do that.
Yes.
Yeah. I'm looking into it, Dr. Sneha.
Yes, please. Thank you so much, sir, for your blessings. And with this, by the time Madam joins, I request Dr. Rajendra Singh Pardesi, who is the AMOGS president, and of course my mentor, who is constantly guiding me, almost hand-holding. And I especially thanks her, because as a high-risk, as a hardcore obstetrician, I always wanted to take up this committee as a chairperson. And sir has given me this opportunity to work for this committee. So it's my great pleasure to have you, sir, here. And we would definitely like to hear from you, sir. So all of you know, sir is the AMOGS president at present for the coming 2 years. And sir is a very humble human being, very helping to each and every member of AMOGS. And of course, he is guiding many like me. So I would just request sir to have a few words, or to say a few words of guidance.
Good evening, everybody.
respected Dr. P.K. Shah sir, Dr. Shyam Desai sir. So I will request Dr. Sneha henceforth, if Dr. P.K. Shah and Dr. Shyam Desai sir is there, so please on the first row only you should insert their photographs, because I am disciple. My biodata will not be completed. I am disciple of Dr. P.K. Shah and Dr. Shyam Desai sir, and still wanted to be disciple, not president. So respected P.K. Shah
Sir.
sir, Dr. Shyam Desai sir, Dr. Jamuna Devi, Dr. Chinmay, Dr. Chirumanila Lakshmi, Dr. Charulata Bapai, and all. So, first I wish to congratulate Dr. Sneha Boyar for her initiative in GDM, means hyperglycemia in pregnancy. And she has started this initiative, nice initiative, with joining hands, means among joining hands with other societies, Nizambad, Nalgonda, Karimnagar and Mehboob Nagar societies. And with the galaxy of speakers like P.K. Saxena, Sushila Rani, Chinmay Ras, Sneha Boyar, Vidya Thopi, Sita Ramurthy, Vandana Bansal. I think this will be a great event. I wish every success to Dr. Sneha Boyar for her vice presidential election in Foxy. I wish every success to Dr. Suman Sinha and Dr. Aruna Suman also for their election as chairperson. And thank you so much for inviting me. My best sincere wishes to this webinar. I don't want to be in between you and scientific content. Thank you so much for inviting.
Sir, thank you so much, sir. In fact, this is your platform and all of us are getting benefited by this. So I welcome Dr. Jamuna Devi, madam. Welcome to this program. A very good evening to you. And I request Bhavna to share madam's CV so that we can have the official introduction. And definitely, madam, I request you to share your words of wisdom here and bless all of us. So,
thank you, Dr. Sneha. This is Dr. Chinmay here.
yes.
And it's really a pleasure for me to be part of this wonderful program that you've organized. And it's really great to see Dr. P.K. Shah sir and Dr. Shyam Desai sir and Rajan Singh Pardesi sir, because they're always seniors who inspire us. And in this line, Dr. Jamuna Devi is one of our stalwarts from Hyderabad. And madam, I don't know, after COVID, she decided to have this gray hair style, but she's one of our style icons, I must say, from Hyderabad, where we look up to madam for many things, not only in obstetrics and gynecology, but a lot of life skill advice I have always taken from madam. All of us have done very well in obstetrics and gynecology and our CVs read as such. But the important thing about Dr. Jamuna Devi is she is also an LLB and has a huge knowledge in terms of the legal aspects of medical cases. She's helped a lot of practitioners here with those kind of advices and has been a very active member of the Indian Menopause Society also. So madam is like a force to reckon with in Hyderabad, somebody who can really guide us not only through obstetrics and gynecology cases, but through a lot of things in life. So without standing between you and ma'am, I'd request ma'am to say a few words as the guest of honor of this program.
Thank you so much for the wonderful words you have said in favor of me, Chinmay. You make me feel so proud. Thank you, Sneha, for involving in this program, which is so much needed. Medical disorders are really going up in this community now, and especially the GDM, that hyperglycemia in pregnancy is, we see almost, I think 1 in 5 women, we do see these issues. And now all the stalwarts who are going to speak about these things will come out with some which will be useful to the delegates who are attending today, so that we can make some change in our women. And definitely this webinar is going to be very useful. And I think I will not take much time, and wish you all the best, Sneha, and all the delegates for being with us. And thank you so much.
Thank you. Yeah, thank you so much for your words of guidance and blessings, of course. With this, I just take this opportunity to express my gratitude towards all my mentors, respected Dr. P.K. Shah sir, Dr. Shyam Desai, Dr. Jamuna Devi, Madam, the guest for today, Dr. Rajendra Singh Pardesi, AMOGS President, and Madam Sujata Darviga, AMOGS Secretary. All the three speakers, the first one, Dr. P.K. Saxena, Dr. Sushila Rani, Dr. Chinmay Ratha, dear friend, and Chairperson of Perinatology Committee. All the chairpersons here, Dr. Aruna Suman, Dr. Vidya Thobi, the ex-chairperson for Food and Drugs Committee, and I can see so many other dignitaries here, all dear friends also, the coordinators, as we already said, Dr. Lakshmi and Dr. Charulata Bapai, and the MOC for today's program, Dr. Suman Sinha. I thank all of you for being here and gracing the program and blessing me and the program. Thank you so much. And with this, I hand over the program to the MOC and the coordinators for the academic session. Thank you so much.
Thank you, Sneha Madam, for your beautiful words. And with this, we come to the end of the inaugural session. And now we quickly move on to the academic part of our program. And for this, I invite our coordinators, Dr. Lakshmi Chirumamila and Dr. Charulata Papai. So can I have the CV? Yes, thank you. Dr. Lakshmi is the Clinical Director and Senior Consultant Fertility Specialist in the Nova IVF Fertility Center, Hyderabad. She is FRCOG and she is practicing only fertility since 2006. She is Joint Secretary of Obstetric and Gynec Society of Hyderabad Society. She has done her fellowship in fertility and IVF from the Royal Infirmary of Edinburgh, UK. Her special interest is natural cycle and minimal stimulation IVF, pelvic ultrasound, male factor infertility, endometriosis, and fibroids affecting the fertility. And she is associated with British Fertility Society. So can I move to the next CV? Welcome, Dr. Lakshmi. And my friend, Dr. Charu, is here. So she is the director of the GEMS Hospital and Endoscopic Center at Aswin Hospital, Pune. She is presently the chairperson of Study on Female Breast Committee, FOXY, honorary consultant of Dinanath Mangeshkar Hospital, Cloud9 Hospital, Pune. She has been trained in gynec endoscopy at BEAMS, Mumbai under Dr. Rakesh Sinha. She has done a training course in endoscopy at KL, Germany also, and has won the best video prize at IAGE, Hyderabad. Presented numerous videos and presentations at national and international conferences. Welcome, Dr. Charu, and I hand over.
Yes, Charu will be joining later. I would just request the chairpersons and coordinators to make the CVs a little short so that we can enjoy the academics. Thank you so much. So Dr. Lakshmi can take up.
Yeah, Dr. Lakshmi. Yeah.
Okay, thank you so much, ma'am, for giving me this opportunity. May I have the first slide of the chairperson, please? Dr. Banushree. Dr. Banushree is from Bodhan in Telangana. She is a consultant gynecologist in Maruti Prasanna Maternity Hospital. And she's now working as chairperson of Women Doctors Wing, Bodhan, and she is the joint secretary of IMA Bodhan, and she is also my senior from my medical college. Welcome, Dr. Banushree. And Dr. Aruna Suman is all of us very well know about her because she has served as a joint secretary for FOXY in 2021, and she's an active member of our Obstetric Society of Hyderabad. And at the present moment, she is working as a professor and HOD and vice principal of Jagatyala Medical College. And she has received so many honors in her whole career. And she is also contesting as the chairperson for endocrinology committee this year. And I would request you all to vote for her and elect her for this position. And she's a wonderful human being more than anything else. Welcome, Dr. Aruna Suman, and I hand over the session to you.
Is Dr. Aruna here?
Yes.
Dr. Banushree,
Yes.
can you introduce the speaker, please?
Yeah. Good evening, all. Lakshmi, are you here?
Thank you.
Yeah,
Yes.
please.
Thank
go
you,
ahead.
Dr. Sneha. Thank you so much for this opportunity. And it feels great to be part of your webinars because you're very academic. I know how much hard work you do, even in the community health services also. I congratulate you for this. And Dr. Bhanushree, can you please introduce her?
Yes, madam. Are you hearing?
Yes, yes, you are audible. Please go ahead.
Okay. Good evening, all. Thank you for giving this opportunity. I want to introduce Dr. Paiki Saxena. She is working as a professor in Department of OBG, LH Medical College, New Delhi. Her designation is Director Professor of OBG, FICOG. She is a winner of 32 gold medals, including CS Dons Award, Orion Award, and Best Paper in Foxy Journals. Editor of 6 books, published more than 230 articles and chapters. Executive member of Indian Fertility Society, in charge of infertility clinic and IUI lab in LH Medical College. Executive member of New Delhi Diabetics Forum, ISAR and ICMR DST. Endocrinology Committee of Foxy, Safe Motherhood and Reproductive Endocrinology Committee of AOGD 2022. Now I welcoming Dr. Paiki Saxena. Over to Madam. Thank you.
Thank you, Madam, for such an elaborate introduction. Is my screen visible?
Yes,
Yes.
And
but please put it in a slideshow. Yes.
I have put it in the slide show. Is it full screen now?
Yes.
Yes. Okay. Thank you so much. Dr. Sneha, I would like to take this opportunity to thank you for making me a part of this wonderful academic feast. And I'm very honored and very happy to be a part of this place where so many stalwarts are there. So today the topic I'll be speaking on is screening for hyperglycemia in pregnancy. My name is Paiki Saxena. It is not Paiki. I will just take this later. Yeah. So 21 million pregnancies are complicated by hyperglycemia every year. And out of this, nearly 3 to 4 million are detected and treated. And still negligible amount receive postpartum follow-up and lifestyle advice. This slide is not moving.
You can just click once and
so hyperglycemia is a teratogen which has detrimental effects on the fetal organs. So the biggest challenge is that somehow we need to, actually I can't see the slide. Can you all see my slide?
Yes, ma'am, you can see.
Yes, we are able to see your slide.
We are able to see, ma'am.
Okay. I am not able to see it.
No, just
the challenge is to unmask the already existing diabetes, which is the first and the most important step to curb the epidemic. There is some problem. I can't move.
Have you minimized the Zoom window? Is it? Just try and manage that.
Yeah.
Click on the Zoom window.
On the Zoom window. No, now something else is opening. I'm not able to move forward, Dr.
You want just unshare and share, no? Maybe that is just.
I will do that.
You can do that.
Just like, excess of everything is bad. Sometimes too many windows inside our computers also.
Yeah.
They cause problems.
I'm not able to stop. Okay.
Just unshare and then share again.
Yeah. Share.
Just click on that green.
Stop share.
Yes, stop share. Yes.
Is it visible now?
Yes, absolutely.
Yes. Is it visible for you? Just take that.
It is.
Yeah, just move one slide up and one slide down.
Yeah.
You can see now?
I can
Or maybe
see.
you can undo that
Ma'am.
this thing, that pointer of yours. That pointer
Yes,
comes-
Bhavna, if you can help her, please.
Yes, ma'am. Ma'am, actually, there is an issue with PowerPoint presentation that if we share the slide share directly while doing the
Hang
PowerPoint.
on, now it will be fine because she had
Okay,
that
I
laser
think
pointer
it
on.
was because of
Yes.
the pointer.
Yeah, the
Thanks
pointer's
for
gone now.
pointing that out. So we know that the prevalence of GTM in our country varies from 3.8% in Kashmir to 17.9% in Tamil Nadu. And the prevalence depends on the population which is being tested, the diagnostic criteria which is being used, the year when the study was conducted, and also on the socio-demographic differences and the individual habits. So hyperglycemia in pregnancy can be divided into two categories. There is diabetes in pregnancy and GTM. Diabetes in pregnancy is also known as pregestational diabetes or overt diabetes or type 1 or type 2. And it is diagnosed if the fasting plasma glucose is more than equal to 126 or the random postprandial or post-glucose value anytime during pregnancy, during labor, after delivery, before pregnancy. If anytime it is more than 200, then straight away we say that this is diabetes in pregnancy or overt diabetes. If the threshold is between 140 to 199, then it is GTM. So there is a perpetual controversy. GTM is a very controversial topic, but I think the maximum amount of controversy is in the screening and diagnosis of GTM. There are nearly 14 guidelines across the globe, but there is lack of uniformity and validation. There is confusion among cervix providers. Even in the same city, I'm sure everyone is doing different types of tests. Even in our big tertiary care hospital, different units sometimes are doing different tests. So the guidelines which have been recommended for Caucasians may not be appropriate for Indian population. In the NFHS 5 data, we can see that only 21% of pregnant women utilized full antenatal coverage. So there is a need for a screening strategy that would take into stock the local prevalence of GTM, available infrastructure, convenience, and scientific validity of the test. GTM has a legacy. We all know that GTM begets GTM, and there is a vicious cycle. Diabetes epidemic is soon going to become a pandemic. Nearly 2/3 of the women who have diabetes in pregnancy or GTM in pregnancy are subsequently going to develop GTM in the next pregnancy. And within 5 years, 50 to 70% of them are turning into type 2 diabetes mellitus. The fetal complications are initiated in the intrauterine period itself. And besides adverse perinatal consequences, there are long-term serious implications. The children are getting diabetes and other NCDs. So GTM offers a unique opportunity for initiation of strategies to prevent this problem. I'm sure that we all know that Indian women have 11 times higher chances of developing impaired glucose tolerance during pregnancy. So there is no scope of selective screening because the selective screening is advocated by NICE guidelines, and that would miss nearly 20% of GTM cases as compared to the universal screening. So most of the guidelines, as you can see here, Indian guidelines, DIPSI, PIGO, International Association of Diabetes for Pregnancy Study Group, ACOG and ADA, all recommend universal screening. Frequency of screening, DIPSI recommends that it should be done in all the 3 trimesters, whereas the Government of India guidelines recommends that it should be done in the first trimester, and then it should be followed up again at 24 to 28. The prevalence of GTM is significantly higher. As you can see here, it is 17.8% in the urban population as compared to only 9.9% in the rural population. Also, we have some high-risk factors like age more than 25 years, BMI more than 25 years, and family history of diabetes, which are strongly associated with GTM. This is one of our published study. Again, here we can see that age more than 25, BMI more than 25, family history of diabetes, previous history of abortions and stillbirth are strongly associated with GTM. So when should we screen? Should be in the first visit or conventionally as we were taught in the 24 to 28 weeks, because the maximum amount of glucogenic hormones are being produced at 24 to 28 weeks. So probably at that time, we will be able to catch mostly all the women, but then we would have missed so many women who are already positive in the first trimester. So in a hyperglycemic woman, we can see that each islet cell functions as an endocrine organ and develops at 10 to 11 weeks of gestation. Maternal hyperglycemia leads to early metabolic maternal imprinting, which will affect the fetal growth. And as per the Barker's hypothesis, adult disease originates in the fetal life. We also need to remember that severe macrosomia apparently manifests as early as 11 to 14 weeks. So there is a need for testing for GDM in the early weeks of pregnancy. This is a big study done by Dr. Sashaya et al. And they have screened 11,785 women across all the 3 trimesters. And what we find here is that 31% women were screened positive in the first trimester itself, 42% in the second trimester, and they were able to pick up 25% in the third trimester. The same is emphasized in this other study where they screened 4,151 women and found that 38.7% developed GDM before 24 weeks. So as I said, there are about 11 international bodies which have given different criteria to diagnose GDM, but the most commonly used ones are these 6. So out of these 6, the ACOG guideline is the only one which is 2-step test, in which there is a screening test, you do a GCT. If the screening threshold is 140 or more, you call the person in the next visit in a fasting state, give 100-gram glucose load, and then judge her by the thresholds given by the NDDG criteria and Carpenter question. I'm not going to elaborate, but I'm sure you can make out how much different is the threshold in the Carpenter question and NDDG criteria. So now we need to talk about the DIPSI guideline, which was laid down in 2004 and have been recommended by the Indian guidelines. In this, when the woman comes in the fasting or non-fasting state, in the first visit, she is given a 75-gram glucose load, which is mixed in a glass of water, and she is told to drink it within 10 minutes. The time is noted, and after 2 hours, we do a blood sugar level. If it comes more than 140, then she is diagnosed to be GDM. So all these 1-step tests are screening as well as diagnostic test, unlike the ACOG, which is the 2-step test, where they have a screening test followed by a diagnostic test. So out of these 6 may say 1 is ACOG. So 3 are recommending, 2 are post-glucose value of 140. Please note it here. The other important criteria is the International Association of Diabetes for Pregnancy Study Group criteria, which was laid down in 2010. It was adopted by American Diabetes Association in 2011 and WHO in 2013. This is based on the HAPO study, the Hyperglycemia and Adverse Pregnancy Outcome Study, where they enrolled 23,316 women, and they found that there was a continuous positive correlation between maternal plasma glucose and the adverse feto-maternal outcome, which are these all. But the risk of poor pregnancy outcomes is associated with hyperglycemia, which was continuous, and there was no inflection point. That is, even below the thresholds which was chosen by the IADPSG guideline, even below that, patients were having adverse feto-maternal outcome. So the drawbacks of the IADPSG criteria are that HAPO study was not done in Southeast Asian population. The antenatal patients generally do not come to the ANC in a fasting state. It is very difficult. They are already having nausea. So asking them to come in a fasting state from their homes is very difficult. It is labor intensive. They draw the sample 3 times. 3 times the woman is pricked, 3 times the money is spent. and the woman has to wait for 2 hours during this time. It is inconvenient for the patient, and the fasting plasma glucose that they are doing in these patients is not reflective of the postprandial value, which is actually the hallmark of GTM. HbA1c is recommended by IADPSG criteria, but it is not practical to do this in the resource limited areas. And also the WHO has found that the HbA1c sensitivity is not very good. So why do we recommend DIPSI guidelines? It has major advantages. DIPSI guidelines have been extensively tested on the Indian population. It is convenient, practical, feasible. Fasting is not required. Patient may come fasting or may not be fasting. It can be done then and there. It is a single step, single value, single visit test. It is cost effective. Even when DIPSI says to repeat in all 3 trimesters, it is still going to be cheaper than IADPSG. It can be done as a point of care test with glucometer. So then and there, if the 2-hour blood sugar level is more than 140, you can counsel the patient regarding the risk to the mother and the baby and start her on medical nutrition therapy. And if the values are higher, you can tell her to come with self-monitoring of blood glucose and start medical pharmacotherapy if required. And the scientific validity has also been proven by Indian studies. So this is a very important study by V. Balaji, where they compared the capillary blood glucose with the venous sampling, which is the gold standard in the community-based study. And what they found was that glucometer testing had a sensitivity of 80.2 and a specificity of 98.5%. The area under the ROC curve was 0.991. And therefore, the Ministry of Health and Family Welfare has recommended that DIPSI tests can be done by glucometer. This is one of our studies which we did in Lady Hardinge Medical College, where we compared the diagnostic accuracy of non-fasting DIPSI with the HbA1c and fasting WHO criteria on 800 women. At that time in 2017, the prevalence came out to be 6.25%. The sensitivity, specificity, and diagnostic accuracy of DIPSI came out to be very good, 98.25%. This was followed by this other study where we compared the diagnostic accuracy of DIPSI with the gold standard Carpenter-Couston and NDDG, which are endorsed by the ACOG committee. And what we found was that the diagnostic accuracy of DIPSI as compared to Carpenter-Couston was 95.8%. And with NDDG also, again, it was 95.5%. This was the first study to show that GTM women diagnosed by DIPSI had a significantly higher rate of cesarean section, mean birth weight, and macrosomia as compared to normoglycemic women, which implies that DIPSI correlates well with fetal-maternal outcome. On doing a detailed analysis of our data, what we found was that maximum number of women who had deranged blood glucose were in the 2-hour plasma value group, and both by Carpenter-Couston and NDDG criteria. And most of these women, 93% in both 2-hour glucose value was deranged. Most of these women also had deranged fasting 1 hour and 2 hours. And as our DIPSI is picking up hyperglycemia at this 2 hours, it is able to pick up nearly all these women. This is the other studies which have been done in Indian patients, and all have proven the scientific validity of DIPSI. So what is the rationale between DIPSI cutoff of 140? As you can see here, when there is a loss of 50% of beta cells, then it is manifested as impaired glucose tolerance. So when the impaired glucose tolerance is considered as a red flag in non-pregnant patients, so why not consider it as red flag during pregnancy? Because in pregnancy, the glucogenic hormones are there and insulin resistance is going to be increased further. Just give attention to this statement given by FIGO 2015. The IADPSG criteria has been based on odds ratio of 1.75 with respect to mean of adverse fetal-maternal outcome, and our DIPSI criteria is based on odds ratio of 1.5. The FIGO clearly says 2-hour glucose cutoff value of 153 as selected by IADPSG may not be as efficient in picking up women with fetal overgrowth as those by odds ratio of 1.5, which corresponds to 140. So our findings are endorsed by international agencies also. The current status of DIPSI, the national guidelines recommend DIPSI, FOXI, Endocrine Society of India, Indian Society of Neonatology, RSSTI, API, all these societies recommend DIPSI to be the test of choice in Indian population. Even the international societies like IDF, FIGO, and WHO recommend that this can be done in resource-constrained settings. So now I'm touching on a very, very important point. Dr. Sashaya, who is the father of GDM in India, his path-breaking concept for primordial prevention of diabetes. Is it possible? This paper has recently been published, Prediction and Prevention of GDM and its sequelae by administering metformin in early weeks of pregnancy. So, Hernandez et al. Did a pooling analysis of 12 studies involving 45 years of data, and they found that the glycemic targets used in the management of hyperglycemia needs to be lowered. The fasting they recommend is 71, 1 hour less than 122, and 2 hours less than 110. Few studies have found that HbA1c of more than 5.3%, which corresponds to postprandial blood sugar values of 110 during first trimester of pregnancy, predict GDM, and they are linked to macrosomia and other adverse perinatal outcomes. So a postprandial blood glucose of more than 110, if performed at 8 to 9 weeks, may help to identify a pregnant woman who is at risk of developing GDM as she progresses during pregnancy. So we did a study in Lady Harding and also in Chennai, which showed that the postprandial blood glucose of 110 at 8 to 9 weeks had a diagnostic accuracy of predicting GDM up to 80%. So if we are able to predict GDM by this simple test at 8 to 9 weeks, we can start medical nutrition therapy and a low dose of metformin to prevent development of GDM and the intrauterine programming and its sequel. So this is a very, very important slide, and it is talking about the fetal glucose steal. Why have they chosen this important figure of 110? The renal threshold for glucose in the fetus is about 110. If the mother's blood glucose values are more than 110, the glucose is going to pass to the fetus, causing fetal hyperglycemia. In response to that, the fetal pancreas are going to produce more insulin, which causes an exaggerated flux of high level of glucose from the mother to the fetus, thus lowering the mother's glucose levels. This phenomena is known as the fetal glucose steal and can lead to intrauterine programming of fetal pancreas, which develop at 11 weeks. And these women, we may not be able to detect them with oral GTT. Otherwise, they are having macrosomia, they are having polyhydramnias. I'm sure all of us have seen such patients in our clinical practice. Therefore, it is very important to bring down the blood glucose levels before 11 weeks by initiating intervention. DIPSI guidelines have been again released in 2023, where they have done subcategorization of glucose intolerance in pregnancy. GTM, we already know, it was blood sugar more than 140. Gestational glucose intolerance was also defined earlier, more than 120, but less than 140. These also lead to adverse pregnancy outcome and future chances of developing type 2 diabetes mellitus. Now this important new identity has been introduced, the early gestational glucose intolerance, or the EGGI, for 8 to 12 weeks. So if the patient comes and 2 hour postprandial, not post 75 gram glucose, is more than 110, we can understand that these women are prone to develop GTM. So again, I would like to say that at 8 weeks, if the postprandial blood glucose comes to be more than 110, intervention in the form of MNT and metformin should be started, so that by 10 to 11 weeks, we have a grace period of 2 weeks to bring the level down to less than 110. If the level is less than 110, there will not be an increase in the fetal beta cell insulin secretion. But if the levels we are not able to bring down below 110, and if it is more than that, then we do not have enough time available to achieve this threshold. And this will lead to fetal beta cell secretion of insulin. And as we know that by 8 weeks of gestation, most of the embryogenesis is completed, we can start metformin. If the postprandial blood glucose is more than 110, we can start MNT and metformin 250 milligram twice a day, which can be continued throughout pregnancy to keep the glycemic levels less than 110. Metformin is safe at this time because embryogenesis is already over. And recently, the European Union, which is the regulatory body of Europe, and the NICE guidelines also say that metformin can be safely used from preconception throughout pregnancy when the likely benefit is more than the risk. So to conclude, Indian population is diverse and variable. Hence, judging international criteria on Indian population may not be the best approach. Indian problems need Indian solution. What Dr. Sachaya says is this: the crux of the problem is to identify the already existing undiagnosed diabetes for low and middle income countries like India, which have high diabetic burden and suboptimal antenatal coverage. Universal early screening with a single step DIPSI criteria is convenient and evidence-based. So the most efficient way to alleviate this epidemic of diabetes is to focus on the fetus for the future, which is the dictum given by Dr. Sachaya, and timely action taken now in early screening of all pregnant women for glucose intolerance and achieving euglycemia by MNT or pharmacotherapy, and ensuring adequate nutrition and preventing this vicious cycle of intrauterine programming will prevent the epidemic of diabetes. I thank you all for a patient hearing.
Thank you very much, Dr. P.K. Saxena. That was an excellent talk. You have covered everything, especially the hyperglycemia should be corrected around 8 weeks. That's an excellent take-home message that you have given. Yes, by 11 weeks, we'll have to control the blood sugar. Working in a government setup, we have OP of almost 200, 150 to 200. So whenever the first time the woman visits us, we do RBS. If that is high, we do fasting postprandial blood sugars. But definitely every woman we screen around 24 to 28 weeks. Thank you so much. That was an excellent talk. And thank you, Lakshmi, for that great introduction. And thank you, Dr. Sneha, for this opportunity. Dr. Banu, would you like to say something?
No.
And yes, we'll have to control the blood sugars to prevent the high risk factors like macrosomia, preeclampsia, and shoulder dystocia. These are the main complications that can occur besides congenital anomalies.
We need to recognize and give importance to our Indian scientists. Dr. Sachaya, way back,
that's very nice.
2004 has given this idea of DIPSI, which is such a convenient and such a simple test which can be done everywhere. I'm sure all of us are getting patients, they are not even getting a BP done, hemoglobin done, let alone blood sugar. So this is a test which can be done by all facilities, and glucometer as a point of care with proven scientific validity. I think it's a very great idea. And sir, this idea, primordial prevention of diabetes, I think it's an excellent idea. And we have put up a multi-centric ICMR project on this. And Dr. Anjalakshi madam in Chennai and myself in Lady Harding are doing it. And I will be very happy if you people can collaborate with us.
One question, Saxena.
Yes, ma'am.
Yeah, because see, the laboratories, when we send for examination of this GCT and all those things, the question comes whether the patient when goes to the laboratory, then from there they will ask, should I give 50 or should I give 75? So why your organization doesn't, coordinate with the laboratory people, say that, okay, you have to give this for a pregnant lady. So there is no confusion about, giving 50 or 75. That's
Dr.
just a
Jamuna,
suggestion.
actually, the Indian guidelines very clearly say 75 grams, but the service
Yes.
providers themselves are confused. There are 14 guidelines, ma'am. So some are trying to follow the American guidelines. Some are trying to follow the International Association guidelines. Some are trying to follow American diabetes guidelines. And the physician friends, most of them are trying to follow the ADA guidelines.
The ADA, right.
Confusion comes.
So simple solution, Dr. Picky, what I always do when I give this talk, I just say there are so many guidelines and you need not know about all this, because FOXY, NHM, DIPSY, everybody says that 75 gram single step. So obesity, that's all. So I think it's a need
adapted by Government of India.
What Indian
Yes, Dr.
population
Sneha.
asking 75
It is Government of India.
Yes, that should be the policy.
And my
Perfect.
namaskar to PK Shah sir and Vidya Tobbi madam. And Jamuna madam.
Nice to see you, sir, after a long time.
Jamuna madam.
Sir, you are mute, sir.
Namaste. PK Shah sir, namaskar.
Namaskar, namaskar.
Thank you, Dr. PK Saxena. And can we continue with the next topic?
Yes,
Thank you,
please.
Lakshmi.
Yeah, you can, Lakshmi, you can go for the next section.
Can I have the PPT of the chairpersons, please? Dr. Vidya Tobi ma'am, she is the current president of KSOGA, and she is a professor and head of the Department of Obs and Gynae College, Medical College at Vijaypur. Again, she has hosted a lot of posts. She was the chairperson for Food, Drugs and Medico-Surgical Equipment Committee. She got the Best Committee FOXY Award in 2020. And she was an ICOG Governing Council member of 2021 to 23. And she has presented a lot of papers at national and international conferences. And her focus and speaker at national and international conferences. She had multiple publications in various books, and she has contributions to FOXY also. Welcome, ma'am. And Dr. Poonam Chandramati, she's the director of Sri Chandra Hospital, Karimnagar. And she is a professor of Chelmeda Anandrao Institute of Medical Sciences. And she is present FOXY president for Karimnagar Obstetrics and Gynecological Society. And she has been practicing for the past 18 years. Welcome, Dr. Chandramati. And the stage is yours. Please introduce the speaker.
Thank you. It is always a pleasure to introduce my dear friend, Dr. Sushila Rani. And she is so close, and she has deliberated so many talks on diabetes, that whenever I think of diabetes in pregnancy, I always think of Sushila Rani. Anybody asks me, any Karnataka speaker on diabetes, I always tell Sushila Rani. And I think she is an expert. She's a DIPSY member. And we know her for her so lucid talks whenever she talks on stage. They're straight away from her heart and her experience. So she's a medical director, consultant, Manjushri Specialty Hospital, Bangalore, president BSOG 2008-2009, president Indian Menopause Society 2014 and 17, chairperson BSOG PG Forum till 2021. And she's a great teacher and academician. So she is going to talk with us today on management of diabetes. And as we were discussing when we were talking about screening of diabetes, we also have so many guidelines and also FOXY guidelines. And the main goal of diabetic management during pregnancy is to ensure the safe fetal-maternal outcome, one thing, and the prevention or delay of diabetes and cardiovascular diseases in the mother as well as in the child. So over to Sushila to throw more light on this. I think after her talk, many discussions definitely will take place, and we learn better and better when we interact with each other. Thank you very much.
Thank you, my dear chairpersons, especially Dr. Vidya, for those beautiful words about me. And thank you, Dr. Sneha, for thinking of me while planning this program. Thanks to everybody on board here. I've been given 15 minutes to talk on a topic which is so vast, and I'll try to do justice. And if there is anything beyond the scope of this talk, we will take it in the question and answer session. So when we talk of diabetes, we are talking about two things. One is the pre-gestational diabetes and the gestational diabetes. The pre-gestational diabetes is only 16%, and the rest of it is almost close to 80%, 76%. But having said that, we are seeing more and more of pre-gestational diabetes now. So the management of hyperglycemia in pregnancy, whether it is due to pre-gestational or gestational diabetes, there are two things that we need to take into consideration. One is the glycemic management and the other is the obstetric management. Now let's look at the glycemic management. This chart has been put up earlier by Picky, and we said that the sugar values during pregnancy are far, far lower than what is seen in a non-pregnant person. So if we cannot corroborate those values that we see in non-pregnant women to pregnancy, and that is why we sometimes don't appreciate physicians managing the blood sugars, because they don't realize that the values in pregnancy are much lower. Now, what are the targets that we need to have for diabetes?
I think you need to swap your display because it's coming in double views.
Yes.
Up there, you change it to swap displays.
Okay.
Or slideshow. So it's coming in 2 slides each.
I think it is iPad.
Yes, you can.
Yes, do that.
Is it okay now?
Yes, perfect.
Thank you.
Yeah, I'm glad it is. Glad to have pointed it out early on. So the fasting blood sugars we need to have between 80 and 90, and the 2-hour post-meal blood sugar less than 120. And then what is the idea is to have a birth weight which is between 2.5 to 3.5 kg. So this is our main intention during pregnancy. Now, when we say glycemic control, there are two things that we need to look at. One is managing the blood sugars and decreasing the insulin resistance. And this is done with exercise and with modifying the diet. And then the second thing is to decrease the glucose load. And how do we decrease the glucose load? That is by decreasing managing the kind of food that we eat. And the third aspect is increasing the insulin. And this is done by adding insulin and glyburide. Glyburide we don't use anymore because of its problems of neonatal hypoglycemia, etc., etc. So can you see the slide? Hello?
Yes, madam.
Yes, madam.
Yeah. So why keep the carbs at 40 to 50%? Why type of food matters? We know because the carbohydrate, can you see the graph here?
Yes, madam. Yes.
The carbohydrate peaks in the blood as early as 1 hour after eating food. So the carbohydrate that is present, it brings about a high sugar value, whereas the protein that we see takes about 2 to 4 hours to bring about a rise in the blood sugar. And the fat that we get to see in the food, it peaks in the blood sugar only around 8 to 10 hours. So what we need to modulate in our diet is with relation to this carbohydrate and protein. So essentially what we try to do here in diabetes is to decrease the amount, because we Indians, we eat a lot of carbohydrates in our diet. It's a carbohydrate-rich diet that we have. So we need to bring down the rice and add a lot of proteins. So protein deficient, carbohydrate-rich diet we have. So the best way to put it across to patients is to talk about the plate meal method, where we take about half the plate should be full of vegetables, any colored vegetables, green leafy vegetables, and fruits for that matter. and quarter of it should be protein, and the protein can be in the form of dal, chicken, fish, whatever, and only quarter of the plate should be in terms of starch. So if we take a small a quarter bowl of rice, then 3/4 of it should be full of vegetables. Now, vegetables increase the fiber in the diet. They prevent the release of blood sugars, and therefore they are helpful in moderating the blood sugars. So most important message is reduce the grain size, no going beyond 2 idlis, 2 roti, 2 chapati, no going beyond 1 soup bowl size of rice, upma, poha while they are eating, and frequency small, 3 small meals and small snacks. Snacks are not as big as the meals. They're just 1 fruit or half a fruit will make the snacks. And to beat the hunger that is there in between meals, they can have some roasted chana, some nuts or puffed rice, etc. Protein is very important in the form of soya, dals, paneer, lentils, etc. This we can actually tell any one of our assistants, nursing assistants, to explain this to the patient, because in a busy OPD, most of the doctors will not have time to go into details of the diet. And it is something which is so simple. If you teach somebody in your office, they'll be able to tell the patients. Now, 2 things are very important for a woman who's got diabetes in pregnancy. And if you pick up diabetes at the very early stages, say 6 weeks or 8 weeks, there are 2 things that are very important. One is the expected weight gain during pregnancy. Make sure that if she is an average weight woman, she doesn't increase more than 11.3 to 12 kgs. Whereas if she's an obese woman, you need to cut down the weight gain during pregnancy. So this, if you don't tell them, they tend to put on a lot of weight during pregnancy, and that adds to the insulin resistance. So nutrition counseling and physical activity are key to reduce the risk of future obesity, type 2 diabetes, and cardiovascular diseases. And that is why it is extremely important. What is the kind of exercises? Quite often, this is a question that is asked. Brisk walk, even household work, arm exercise. Now, most of our women say, I do all the work at home, etc., etc. But sedentary behavior, sitting in front of the TV or sitting in front of the system or looking at the phone, sitting for a long period of time, that adds 3.8 times odds ratio for adverse neonatal outcome and GDM in pregnancy. And this is done by our own setup from Chennai, Dr. Anjana et al. And therefore, these days, sedentary behavior has become a major problem. And that we need to mention that unless that is curtailed, the blood sugars may not come under control. Maternal monitoring with MNT is the next thing that we need to look at. If this is not managed, if the blood sugars are not managed with maternal monitoring for 2 weeks, then we need to repeat the 2-hour postprandial blood sugar. If it is normal, then we'll continue it in the 2nd and 3rd trimester. But if it is found to be increased, then we will need to add a pharmacological agent like either metformin or insulin. Now, metformin has been introduced. There was a lot of debate about use of metformin in pregnancy, saying that it can have a lot of adverse effects because it crosses the placenta. But according to our own guidelines, metformin can be used after 20 weeks of pregnancy. But please remember, metformin should not be used if the fetus is at the risk of an ischemic environment. Supposing she has got hypertension in pregnancy, or if there is placental insufficiency, or if there is preeclampsia, or if there is growth restriction, if she is on metformin, please withdraw the metformin. I repeat, if the patient is having any of these features, either a placental insufficiency, IUGR, hypertension, preeclampsia, then if she is on metformin, please withdraw the metformin because it can aggravate the problem. Quite often, metformin can be used along with insulin when the blood sugars are not controlled with just metformin, or when the patient is already on insulin and you want to bring down the dosage of insulin, then we can use metformin. So when do we start insulin? Supposing we find that the blood sugars are at the level of the diabetic range, even at the very beginning of pregnancy, or when we do the glucose challenge test, If the fasting blood sugar is more than 90 or a 2 hours blood PPBS is more than 120 and it is not controlled with medical nutrition therapy, then we start insulin. Or if the sugars are very high, even at the very beginning, then there's no point in, we do need to put them on medical nutrition therapy. But along with that, just the MNT may not be enough. So we'll need to put them on insulin. Insulin is a drug of choice. It is the gold standard in the management of hyperglycemia and pregnancy. But in situations where insulin cannot be used, or women are not are reluctant to take insulin, then metformin definitely comes in handy. Now, there are different kinds of insulin. There are recombinant insulins, and there are insulins which we have been using from before called the regular insulins in PH. The recombinant insulins are Lispro, Aspart, Detamir. They are good, but they need not be given in all situations. The greatest advantage of the recombinant insulins is that they act according, the action is faster and it's a little more sustained, unlike the regular and the NPH insulin, which sometimes may not be able to control the postprandial blood sugars. Now we'll come to the obstetric management. Obstetric management is a little different in women with pre-existing diabetes as compared to women who have gestational diabetes. Now, if we have detected diabetes in the first trimester, that means she has got pre-gestational diabetes, we'll need to evaluate the HbA1c. A high HbA1c does not mean that you need to advise termination of pregnancy. You need to counsel her and tell her that there is a good chance of her developing chromosomal, structural abnormalities. And however, these can be picked up by ultrasound, and therefore a closer monitoring is required. Kindly, we must abstain from advising a termination of pregnancy just because the HbA1c is high. For those women for whom we have picked up diabetes in the first trimester, a fundus examination is important, which most often is not done. A retinopathy evaluation is also required. We also need to get a serum creatinine done at least once during pregnancy, because many a times this is the only time that they come to a doctor, and this evaluation is very important. Yeah, a dating scan is required because the growth of the fetus is what gets affected during pregnancy. So unless you date the pregnancy, you may not be able to evaluate the growth well. A scan at NT scan is very important. Now, NT scan here is not just for aneuploidy screening. It is also to find out if this baby is likely to develop structural abnormalities, which is very common in pre-gestational diabetes. In the second trimester, apart from monitoring of the sugars and checking the optic fundus and retinopathy, fetal echo is very important. And because amongst the abnormalities in the fetus, the cardiovascular abnormalities are very high in a pre-gestational diabetes. So we take every opportunity to check out if there is any abnormalities of the heart. And an anomaly scan at 20 weeks is what is routinely done. In the third trimester, growth scans are very important because diabetic hyperglycemia in pregnancy can affect the growth. Either there can be macrosomia, or if there is some amount of vasculopathy because of diabetes, there can be placental insufficiency and a growth restriction can be seen. And subsequently, monitoring is done in the form of NST from 32 weeks onwards. If there is placental insufficiency, of course, we'll need to do Dopplers to monitor this particular fetus. And tests for fetal well-being will be done after 38 weeks. Now, when we do the NT scan, we usually send for the double marker or for the quadruple marker. What we must remember is that the biochemical markers in diabetes with pregnancy can be altered. The levels of maternal serum, alpha-fetoprotein, estriol, inhibin A, all get significantly reduced with diabetes. And therefore, if we are reading the results just like that without making the adjustments for diabetes, then many of them might be thought to have downs, etc. So it's very important to adjust the MOM values because diabetes can affect these values. Now, amongst the evaluation of the fetal growth parameters, of course, we will look at the fetal biometry. But what is most important is the abdominal circumference, which is the best parameter which correlates with the nutritional state of the fetus. Whether it is a growth restricted fetus or whether it is a macrosomic fetus, it is the abdominal circumference that is the most important parameter here. Any abdominal circumference which is more than the 75th centile, and if it is showing a rising trend in the fetal growth pattern, then this definitely indicates macrosomia. So macrosomia, you can see that all the parameters are going up, all the fetal biometry is going up, and especially so the abdominal circumference, which has reached almost the 95th centile. This indicates macrosomia. So it's very important to identify macrosomia. And how you look for macrosomia, whether you take the perpendicular parameters or whether you take a circumferential parameter is up to you. Management of preterm labor is very important because diabetes in pregnancy can give rise to preterm labor, which is very common. So when a woman comes in preterm labor, what is the kind of tocolytic that we give? Generally, what is advised is nifedipine or indomethacin. Beta-mimetic drugs should not be given. There are a few people who give isoxaprine hydrochloride in the management of preterm labor. In cases of diabetes in pregnancy, this is not advised because this itself can give rise to hyperglycemia. Now, we also give antenatal corticosteroids for women who come in preterm labor. We must remember that once steroids are given, this can cause a rapid deterioration in the glycemic control. It can cause an increase in the blood sugars. Those who are on diet may need insulin. Those who are on oral anti-diabetic agents will now need insulin. And those on insulin will need an increase in the dosage almost 20 to 40%. And therefore, very close monitoring of the blood sugars and an increase in the insulin dosage is warranted. However, there are many people who do give steroids even when they do an elective cesarean section at 37 to 39 weeks. This is not advised. Antenatal steroid treatment at 37, 39 weeks gestation for lung maturation prior to elective cesarean section can have an adverse effect. In fact, it can cause neonatal hypoglycemia with no evidence of reduced neonatal respiratory problems. So there was some nice guidelines earlier saying that if you are doing section at 38, 39 weeks, you will need to give antenatal corticosteroids, but that is not warranted, especially in a diabetic pregnancy. Now, what somebody is worried about in diabetes is stillbirths and gestational diabetes. This could be because of hyperglycemia causing increased insulin, increased oxygen consumption, and therefore giving acidosis, or it could also be due to maternal vasculopathy. Now, how do we identify? Can we predict it with fetal Dopplers? In IUGR, fetal hypoxemia, there is a classic redistribution seen in the fetal Dopplers. In diabetes, there may be acute fluctuations in the fetal blood pH due to fluctuations in the maternal glucose concentration. So these fluctuations in the blood pH cannot be picked up by the fetal Dopplers. With growth restriction, fetal hypoxemia, that can be picked up by the Dopplers. But the fluctuation in the blood pH because of glucose variability, that cannot be picked up. And therefore, Dopplers may be normal even in severely compromised fetuses. So be careful. Just the Dopplers for monitoring may not be enough. Now, stillbirths at term occur because the placenta also grows big in a diabetic pregnancy. If you find a placenta which is of normal size in a diabetic woman, then you will sometimes need to worry because this can cause problems in the fetus and give rise to stillbirths at term. Now, timing of a delivery in a woman with diabetes is very important. And we always wonder, when would it be okay to deliver the baby? Is 38 weeks a good time or 39 weeks? What if there are problems of prematurity since they are functionally immature? Will it lead to stillbirth while we are waiting? Will early delivery prevent all complications for the baby is what we look at. Now, we have FIGO guidelines to help us in making decision. If the woman is very well controlled, GDM on diet, you wait up to 40 weeks. But you don't wait for beyond 40 weeks in any of this diabetic woman. Well-controlled GDM on metformin also between 39 to 40 weeks. But if the woman is on insulin, that means she needs something more to control her blood sugars. So these women, we prefer to terminate the pregnancy between 38 to 39 weeks. Poorly controlled GDM, of course, depending upon the clinical situation, you will have to terminate the pregnancy as and when required. If the estimated weight is more than 4 kgs or more, then definitely we need to offer LSCS. In the absence of obstetrics or diabetes complication, an elective cesarean section is best performed at 39 weeks rather than 38 weeks of gestation. Now, how do we maintain the blood sugars during labor? Intrapartum, we need to see that it is between 70 to 110. If it is more than 180, it can give rise to neonatal hypoglycemia. How do we monitor the sugars? It depends upon whether she's in latent phase or active phase. In latent phase, just like in what you do during pregnancy, you maintain the same way. In the active phase, you will have to monitor the blood sugars at least once in an hour. It also depends upon whether the woman has got type 1, type 2 or GDM. So this is what I was saying. If the GDM is on diet, metformin 6-hourly in the latent phase, it's in the active phase that you need to worry about. GDM on insulin, 2-hourly check is more than enough as long as the sugars are well under control. Can we administer glucose infusion in labor? If a woman is diabetic, some of the physicians don't want to give glucose in labor, but we must remember that in active labor, it is a vigorous exercise and there is a need for glucose. So we have to administer glucose, whether we give it in the form of 5% dextrose or 10% dextrose or dextrose saline, glucose has to be given because it is an energy requirement during labor. And if you don't give glucose and just give them some normal saline drip, then it can cause prolonged labor. Management of glucose during depends upon the type of diabetes. Type 1, type 2 will need lower doses of insulin. GDM and MNT will not need insulin at all. So how do you give insulin? We cannot be giving subcutaneous insulin injections during labor. We'll have to give an intravenous form of insulin, IV insulin infusion in 5% dextrose. I prefer to give 5 units of regular insulin in 500 ml. So that way I'll be giving 1 unit per hour if I'm infusing at the rate of 100 ml per hour. So this is how we monitor we manage the sugars during labor. And if we are planning an elective cesarean section, we'll need to give normal saline for intravenous hydration before anesthesia. 5% dextrose saline is given if glucose levels are less than 70. Then based on the sugar levels, insulin is given. Shoulder dystocia is something that we need to be careful. It is not necessarily a big baby that can give rise to shoulder dystocia. Infants with diabetes mellitus, mothers having diabetes mellitus tend to have a differential kind of fat distribution, wherein the bisacromial diameter or the shoulder width becomes much more. Therefore, one can be taken unawares by a shoulder dystocia in labor, but it can be managed. And once it is managed, it's very important to document and debrief the patient, because this is one of the most common causes of litigation in our country. Neonatal hypoglycemia can happen, so we'll need to monitor the blood sugars. Anything less than 20 to 40 milligram, glucose has to be given. Early feeding is required. Ask the mother to feed as early as possible in order to prevent neonatal hypoglycemia. Now, even if there are no clinical signs or symptoms of neonatal hypoglycemia, it's important to identify, because even asymptomatic hypoglycemia can give rise to neuronal cell injury, cerebral damage, and long-term neurological sequelae. That means you may not realize that the baby is having hypoglycemia, and while it can give rise to a lot of neurological abnormalities, and therefore a prompt identification and treatment is required. What about insulin after delivery? Most often the insulin requirement comes down, and those on GDM, those on diet and oral antidiabetic agents can be managed with just a modification of the diet. Breastfeeding is important in all women, but it is extremely important in women who have hypoglycemia and pregnancy, because it can help both the mother and the baby. It can prevent adiposity and the development of diabetes in the baby. It can prevent the mother who is exclusively breastfeeding from becoming over-diabetic. So a lot of importance is given to breastfeeding. And in the postnatal period, it's important to talk about diet. It's not that she is delivered that we give up on the diet. Diet is important. Exercise is important. She needs to go back to her pre-pregnancy weight. So exercise is extremely important. Weight reduction, contraception, so that the next pregnancy is a planned pregnancy. We'll need to do a glucose test to classify her diabetes in case we picked up diabetes after 24 weeks, and breastfeeding, like I said. So the risk of developing diabetes is highest in the first 6 months. And amongst the South Asians, the conversion to diabetes happens very rapidly within 1 year. So it's very important to pick up these women. In fact, you need not wait for 6 weeks to do a repeat GTT. You can do it even after 48 hours, which I have started to do, and classify the woman as having diabetes. Now, when to call for follow-up, 6 weeks to 6 months, yearly thereafter. It's not that at 6 weeks you find it is normal, you forget about it. Every year on the baby's birthday, she has to get an OGTT done. So our conversion to diabetes is much, much higher than other populations. So what is the kind of test that we need to do? It is not the DIPSI test, but the WHO 75 grams OGTT, where you give 75 grams of glucose and check the fasting and the 2-hour blood sugar. If it is with more than 126 and more than 200, you call her as diabetic. Most often our women are in this range where it is between 100 to 125 and 140 to 199. This is called as a pre-diabetes. And any woman who develops diabetes during pregnancy, I feel should be classified as a pre-diabetes. Constant watch is required to make sure that her diet is normal, she is exercising, and her blood sugars are monitored on a very regular basis. So target glucose levels in labor 70 to 110. Women on lifestyle modification only do not need insulin in labor. This is what I told you earlier. Planned cesarean sections and induction of labor are done early morning. Immediately after delivery, the dose of insulin and type 1 diabetes mellitus is reduced to half or 1/3 the previous dose. And women on lifestyle modification only with the diet and exercise need to continue it after delivery. So obstetricians are the primary care physicians for many women whose first and only contact for healthcare is during pregnancy. And therefore, I feel obstetricians play a major role in bringing awareness and providing postpartum follow-up. So, my dear friends, let's take this golden opportunity to make sure that that our women are taken proper care, because they don't go to doctors on a regular basis and they come only to us when they are pregnant. And we as primary care physicians should make it mandatory that we monitor their blood sugars, not just during pregnancy, but we keep a constant watch on their blood sugars subsequently also. Thank you very much for a patient listening.
Thank you, Sushila ma'am, for the wonderful session. You have enlightened us with so much of information with regard to the management of hyperglycemia in pregnancy. And I thank Sneha madam for organizing such a great webinar and giving me this opportunity to chair this session of medical disorders of pregnancy. And thank you for giving me this opportunity. Thank you, Dr. Lakshmi Chirumamila. And I think over to next session.
Yes. I congratulate really Sushila. In 15 minutes, it is a really Herculean task to cover all management of diabetes. And especially many times I talk on the medical nutrition therapy and diabetes because I was a chairperson of Food and Drug Committee. And I think we have to educate family. Whole family education is required whenever we are treating the patients of gestational diabetes. It is really wonderful. I don't think any questions are there because you have covered everything. If you have any doubts, definitely Sushila will share her email ID. You can directly mail her. She will be, I think it will be very easy to answer. And I take this opportunity to thank
Vidya,
all.
only 1 second.
Yeah.
1 second, Vidya.
Yes.
Somehow I feel our population is a diabetic population.
Yes.
And we are seeing more and more of diabetes. There is no need for us to wait for a woman to become diabetic before we put her on MNT. I think every pregnant woman, and it's a very sensible diet, come to think of it,
Yes,
every
yes.
pregnant woman, or even if they are not pregnant, every member of the family should follow this particular diet. And
Right.
this way, even if we do become diabetic, we'll be able to manage the sugars well. So
Yeah, I agree. And we did study in the North Karnataka, and our diet is a staple diet. And I think we have less carbohydrates, or what jawar we are using. It has got a less glycemic index, and we have to follow certain types of diet to prevent tsunami of gestational diabetes or diabetes in various parts of our country where the incidence is very high. Thank you, Sushila. And I take this opportunity to congratulate Dr. Sneha. She is an able candidate for vice president. Please vote for her. And those societies, from all the societies who they have joined from Andhra and Telangana societies, I congratulate them for joining and enjoying this academic fest. Thank you, Chinmay and others.
Thank you. Thank you so much, Dr. Vidya. Thank you, Dr. Sushila Rani, for that wonderful talk. I congratulate you and thank you all the chairpersons.
So we move on to the third session, and thank you, Dr. Sushila Rani, for your extensive presentation and all the chairpersons for their very valuable inputs. And for this third session, the topic is role of fetal medicine in HIP. And for this, we have chairpersons, Dr. Bandana Bansal Madam and my friend, Dr. Sita Ramamurthy. So I have the CV of Bandana Bansal. She's a obstetrician with super specialization in fetal medicine and interventions. Has huge experience for 28 years in field of obstetric and gynae. And she is ICOG course coordinator and faculty for certificate course in fetal medicine, national coordinator for imaging science committee, FOXI, vice president, Society of Fetal Medicine of Mumbai chapter. And she has been member secretary and expert ethics committee in the Nauroji Wadia Maternity Hospital. So welcome, Dr. Bandana. And can I have the CV of the next chairperson? Yeah. So Dr. Sita, she is presently consultant fetal medicine and obstetrics at Apollo Multispeciality Hospital, Kolkata. She has clinical secretary of Bengal Obstetric and Gynec Society. She's been presently chairperson of Genetics and Fetal Medicine Committee of FOXI, fellow representative of AICC RCOG Eastern Zone, clinical secretary of ISOPAP Kolkata chapter, and has been member of a National Board Specialist Committee of Maternal and Fetal Medicine. So welcome both the chairpersons, and over to you, and kindly introduce our speaker, Dr. Chinmay Rao.
Thank you everyone. Thank you, Dr. Suman, for that kind introduction. And thank you, Dr. Sneha, for giving us this opportunity after that excellent talk of Dr. Sushila on this vast topic of managing diabetes in pregnancy. I'll convey my regards to Dr. P.K. Shah, sir, and all the seniors present here. Greetings, sir. It's my pleasure and privilege to introduce my dear friend, my co-chairperson in FOXI, Dr. Chinmay Ratha, who is the director and lead consultant of Fetal Medicine, Resolution Fetal Care and Research Institute. She's currently the chairperson of the Perinatology Committee, FOXI. You can see the multiple awards she's received. This is just a few in the last 5 years, and to add her she's recently given a talk in the World Perinatology Congress in Italy. So welcome, Chinmay, and she's going to talk on the role of fetal medicine in hyperglycemia and pregnancy. As we heard Dr. Piki saying about focus on the fetus for the future, I think it's very important that when hyperglycemia strikes a woman, we have to decide which is affecting her, the vasculopathy or the poor glycemic control, preventing stillbirths, a lot of issues. So all over to you, Chinmay, for your talk. The stage virtual podium is all yours. Thank you.
Thank you so much, Dr. Sita, Dr. Vandana. Thank you, Dr. Sneha, for this opportunity. And really, it's been wonderful listening to my co-speakers here. And when Dr. Piki said that everything about diabetes is like a controversy, and whatever you say in terms of the screening or management, everything is a controversy. But let me tell you, there is no controversy in the fact that the care for the fetus becomes the most important thing when you start looking at gestational diabetes. And I'll start from where the others ended, that focus on the fetus for the future, because that's how it is. And we know that diabetic pregnancies have lots of fetal risks, starting from spontaneous miscarriages to fetal deaths to growth disorders, malformations, even birth injuries. And of course, the neonatal hypoglycemia, which itself can become a reason for long-term neurodevelopmental delay. You can do everything right as an obstetrician, but if you don't take care of neonatal hypoglycemia, the baby may still land up with neurodevelopmental delay and something which is really, really a preventable issue. So I think the core role of fetal medicine and gestational diabetes is prevent whatever is preventable. An ounce of prevention is better than a pound of cure. So prevention of complications will be the focus of fetal medicine in gestational diabetes mellitus. So this has already been brought about by the previous speakers, that dating of the pregnancy is very important, because whenever you talk about growth problems in the fetus, one important thing is to date the fetus correctly. And most women who have gestational diabetes may be having pre-existing hormonal imbalances, and therefore they may be having very wayward cycles. And it's very important for us to do an early pregnancy scan, date that pregnancy, and use the estimated date of delivery that is established early on in pregnancy as a reference for assessment of fetal growth in the entire pregnancy thereafter. So dating the pregnancy becomes one very important aspect. And as has already been explained, the etiology of fetal anomalies in diabetes mellitus is mostly maternal hyperglycemia, and that is so much of importance that the incidence of congenital anomalies is almost 9 times higher in women with hyperglycemia as compared to those who don't have. In regular pregnancies, we expect 2 to 3% of anomalies, but when there is maternal hyperglycemia, the teratogenesis really increases manyfold, and the reasons at the molecular level have also been understood, that you have functional deficiencies of arachidonic acid and myoinositol. There is inhibition of cellular uptake of certain molecules. There is increased non-enzymatic glycosylation of the embryonic proteins, and starting from free radical injury to many issues, they ultimately lead to a process where the development of a normal fetus is affected. And because of this cellular level of reprogramming, you have abnormal organs that are formed. There is maldevelopment, there is malformation, and there is a disruption of certain levels of cellular growth, and there is at the end of it congenital anomalies. So everything ultimately relates to maternal hyperglycemia. So if you see the primary teratogenesis is maternal hyperglycemia, and if we can prevent maternal hyperglycemia, you do your preconceptional sugars in the woman and avoid periconceptional hyperglycemia, you can prevent the teratogenicity and hence congenital anomalies. So the role of fetal medicine in gestational diabetes actually begins even before the fetus takes shape, because you must intervene in the periconception period, in the preconception period, when you would be able to make a real difference. So as has already been stated, the maternal HbA1c is a very important marker, but just because the HbA1c is high, you need not terminate pregnancies. I am saying here that the higher level of HbA1c correlates with a higher possibility of having fetal anomalies, but do not consider just the HbA1c as a reason to terminate a pregnancy. Even if it is 12, even if it is 11, sometimes there will be good outcomes, and that is just an indication for better fetal surveillance. So prevent maternal hyperglycemia in the preconception period. And in case the woman already has diabetes, what are you looking at? You're looking at possibility of fetal congenital anomalies that affect the cardiovascular system, the nervous system, the facial clefts, musculoskeletal, renal, and GI systems in that order. And therefore, a very thorough anatomy check at the 12-week scan. This is not different for any other pregnancy. You do the same thing for everybody, because screening for anomalies has become a routine in all pregnancies. But if it is a diabetic pregnancy, you do pay more attention to the cardiovascular system and the CNS, because you can go a little extra mile in these pregnancies and do the V sign and Y sign in the cardiovascular system, and look specifically for the intracranial translucency in the nervous system, so that you can screen a little more efficiently for complex cardiac disorders as well as open spina bifida. Now, when your 12-week scan is normal, what do you tell the woman? I am a fetal medicine specialist and I have done your 12-week scan and now everything is fine. Things don't end there. You tell them that yes, the basic scan is normal, but we will review again because some of the organs would develop to a different level after a few weeks. And therefore, we need to keep checking. We need to do a composite screening for fetal aneuploidies, and everything will not be able to rule out anomalies at any condition. So that disclaimer must be told to them clearly, because the teratogenic effect actually may manifest later on. You may not see everything at 12 weeks. So coming to the combined screening for aneuploidies, it is definitely applicable in diabetic pregnancies, but it is more important to remember what Dr. Sushila just told us, that the adjustment for the multiples of median have to be done keeping the diabetic pregnancy in mind. And again, it's something which is self-explanatory because the levels vary in women with hyperglycemia, and therefore all good labs have a TRF column where they write whether the mother is diabetic or not. If you don't know, most people tick unknown, and that is not good. You should know whether a woman is diabetic or not by the time you are assigning biochemical aneuploidy markers. So if the anatomy in the first trimester is normal, when do you see a woman again? There's a little challenge here because we get a lot of referrals for early anomaly scan because the woman is diabetic. Now, when is early anomaly? If you do at 16 weeks, the rationale is open spina bifida or major cardiac anomaly or those kind of things you may pick up here. But the sad part is you can't see everything so well at 16 weeks. People will argue you can see it at 12, why not at 16? But all my friends who do fetal medicine will agree that we are never satisfied after a 16-week scan. We may be satisfied after a 12-week scan, but somehow 16 is not so happy. I'll let my chairpersons comment on it later on, but I think if you have to do an early anomaly scan, do it at 12 weeks and then call the woman somewhere around 18 to 19 weeks, because now again, we have a breather till 24 weeks to take major decisions. And at 18 to 19 weeks, you have a little bit better visualization than 16. And you can at least do a cardiac and, CNS evaluation in better detail than what we see at 16 weeks. But I am leaving it open to the house when to decide. The point is be mindful for fetal anomalies and therefore follow your checklists very carefully. You must do it in every pregnancy, but if she is diabetic, you please take that extra step and cover everything, because even a minor cavum septum pellucidum abnormality might come out to be something sinister later on. So be extremely careful, follow your checklist, do everything and expect everything in a diabetic pregnancy, because the teratogenicity can be enormous, from major CNS defects to open spina bifida to congenital heart defects. Everything is possible in a woman who's had hyperglycemia, and hence go that extra mile and tick every box in the checklist in a woman with diabetes. And looking at cardiovascular abnormalities is very common in these conditions. Heterotaxy syndromes are also seen. So doing a proper evaluation is important, because once you find a cardiovascular abnormality, in today's day and age, there are a lot of advances in neonatology and pediatric cardiology, and people expect that you can offer them corrective surgery, you can offer them life after these kind of abnormalities. So your assessment of the abnormality is very important, and therefore a proper multidisciplinary assessment with the pediatric cardiology involvement to decide whether this is good enough to be offered postnatal surgery, and therefore make a plan for the continuation of that abnormality. In the fetal abdomen, normally we look at these things: the stomach, the bowel, the kidneys, and the cord insertion. In diabetic pregnancies, we do expect defects at all levels, and therefore we look for markers for these specific defects like anterior abdominal wall defects in the form of exomphalos, absent stomach buttle, tracheoesophageal fistula or upper GI obstruction, duodenal atresia, double bubble sign. These are very common associations with women with hyperglycemia. And the problem here is you can have polyhydramnios just because of hyperglycemia, and you can have polyhydramnios as a correlation of upper GI obstruction. So, that is where the science and the art of medicine will mix together, and you will have to differentiate whether it is a structural abnormality or a result of maternal polyhydramnios, but counseling them for the possibility of GI obstructions is also important. Kidneys, of course, they show themselves well, so you know what you're dealing with, but look for these problems in diabetic pregnancies. If it's obstructive uropathy, there is some treatment. If it is agenesis, that's a little sad. The cleft lip and palate are common associations with diabetic pregnancies, and therefore looking at the fetal face and the lips and palate is very important. And this has very good results, because again, if it is resultant of diabetes, then you know it's a pure structural issue. When you have cleft lip and palate, you're worried about everything, including genetic syndromes and other conditions. But when you know that this is associated only with hyperglycemia, if you've ruled out all other things with your regular screening, you can give them a good outcome, because the treatment will be more or less on the structural grounds. The limbs may have sometimes, poor growth or club feet and things like that. And that also can be managed based on their associated features. So for any abnormality that is detected, even in a diabetic pregnancy, the protocol remains the same, that you look at the associated features, exclude genetic correlations, and you try and see if it is lethal or correctable. If lethal, probably terminate. If correctable, then go ahead and look at the attitude of the parents and arrange for perinatal care. So preventing fetal anomalies in diabetic pregnancy primarily starts in the preconception level, and that is preventing maternal hyperglycemia. So suppose you've prevented all that, and now the anatomy is perfect at 19 weeks. Can we now reassure her? At 12 weeks, you said, we'll wait, we'll see at the 19 weeks scan. At 19 weeks, can you reassure her? Because now she says, is everything okay? But you still can't reassure, because there can be evolving abnormalities. For example, hypertrophic cardiomyopathy, GI obstruction, macrosomia and polyhydramnios. All these things can set up in the late trimester, although your mid-trimester scan may be normal. Again, there could be maternal comorbidity in gestational diabetes, and that can alter the fetal prognosis, because you may be forced to deliver the woman before term. So the fetal surveillance in a diabetic mother is to balance the odds of all confounding factors. Normally, we do a 4-weekly follow-up with growth and Doppler. We watch out for evolving abnormalities and do a strict maternal surveillance for a development of PIH, and keep the perinatal care ready. For fetal growth and Doppler, a serial assessment of biometry is very important, because the abdominal circumference may start shooting up in the 3rd trimester in poorly controlled diabetic women, and macrosomia will first present as an increase in the abdominal circumference, and that needs to be watched out for. Similarly, you have to do serial growth scans, and you may be also alert to the fact that in addition to macrosomia, you may also suffer from growth restriction in gestational diabetes. Sometimes women are very, very strict about their diet, and in that process, they actually end up undernourishing themselves, and they end up with having growth restriction, or they may be a primary placental pathology in these cases. So looking at serial biometry is very important in diabetic pregnancies. Dopplers become important when there is hypoxia. So just like Sushila madam said, in all cases, Dopplers won't change, but where there is growth restriction or placental pathology leading to fetal hypoxia, there may be Doppler abnormalities, and the umbilical Doppler directly correlates with the risk of hypoxia and acidemia, and that can be followed in these pregnancies. So when there is altered metabolism in the absence of hypoxia, that is where you may have all the problems that are related to acidemia, but you will not have the classical Doppler changes. And that is where other things like the cardiotocography or the biophysical profile, they can have a direct correlation with fetal well-being. So the biophysical profile is something which we use particularly in diabetic pregnancies. And as you can see, when you see good fetal breathing movements, when you see good active fetal movements, then you can be reassured that this fetus is not exactly suffering from, a major depression of the central nervous system. And therefore, decisions to continue pregnancies for a few more days and waiting at least for a week for another, some more lung maturity can be useful in these cases, because as you know, giving antenatal corticosteroids can also offset the hyperglycemia situation in the mother, and the whole risk-benefit ratio gets altered. So in these pregnancies, accurate surveillance by the fetal medicine doctor and giving you that input whether a delivery is going to be beneficial right now or you are safe to continue for some more time is useful. And with a good biophysical profile, at least for the next few days, 48 to 72 hours, you are safe. So twice weekly biophysical profile sometimes help us in continuing the pregnancy. The false positive rates are high in biophysical profile, but there are very few false negatives. So if a normal biophysical profile, you can actually reassure the parents a lot. So the goal of obstetric surveillance is to identify fetuses at risk in order to intervene timely and in an appropriate fashion to reduce perinatal morbidity and mortality. So for anomalies, you should have a multidisciplinary team, IUGR, stage-based care, and for macrosomia, a good birth plan. But despite everything, what is the key factor? The key factor is maternal glycemic control, because you do everything, you do good Dopplers, you keep everything fine. Unexplained IUFD still remains a major challenge in managing diabetic pregnancies. And both the fetal medicine doctor and the obstetrician will be at a loss if something like that happens. So continuous control of maternal diabetes helps. And the role here is not only maintaining diabetic, hyperglycemia, euglycemia in pregnancy, but also helping the woman, cope up with this so as her to lower her future, life risks for diabetes. This is a short study we had done in our place where we realized that a good percentage of pregestational diabetes is actually discovered in the fetal medicine clinic. So 28 out of 65 pregestational diabetics were discovered because either they were workup for anomalies or miscarriages, or they just had high blood sugars at the time of booking. And many of these women don't agree when you tell them at booking that the RBS is high. When Dr. Aruna was saying that we do RBS at the time of booking, you tell them it's high, they don't agree because they say we don't have a family history, and they go for a second opinion to any lab. And this is again a problem which has already been discussed in the forum, that the labs don't have standard methods of reporting sugars for pregnant women. So I think the role of all of us should be to improve this kind of reporting in the lab and reduce the kind of fallacies that are coming in the interpretation of blood sugars for pregnant women, so that who are truly hyperglycemic may be identified. So in the fetal medicine clinic, what did we modify? We modified counseling the woman and her family as a whole. Instead of just telling the woman that your sugars are high, we call the whole family inside and explain them the problem, and then tell them what are the modifications that are needed. The diet modifications, for example, in India, it will only be sustainable if the whole family follows that diet. Giving a singular diet to one person, sometimes not sustainable. Including the DIPSI method as a screening test and doing group counseling of all the patients who have gestational diabetes helps in improving the compliance to these problems. And this is what has been proven in literature also, that just looking for risk factors will not improve outcomes. You have to look at the woman's beliefs, behaviors, and social environments to affect the change. So in a fetal medicine clinic, by affecting these things, we definitely achieve better compliance and to advice of screening, and motivate the woman positively to accept diet and MNT, and the serial fetal evaluation has been maintained. We also give them checklists for the third trimester should they travel somewhere else for delivery, so that they know what to check in the fetus and how to take care of themselves towards the later part of the pregnancy, and to understand that these lifestyle changes need to be continued even beyond the pregnancy. So to conclude, I would just say that the role of fetal medicine in diabetic pregnancies is to assist the woman obstetrician to help achieve a good perinatal outcome and to prevent whatever is preventable, because prevention is definitely better than cure. And once you optimize preconception sugars and continue that euglycemic mission throughout pregnancies, you will end up achieving a better outcome. So where there is a will, there is always a way. And thank you very much for your attention.
Thank you, Dr. Chinmay. I think it was a strong message that the sugar has to be very well controlled, preconception and in pregnancy. And so for that, screening is as much important. As a fetal medicine, your query on the 16 weeks, I think I am also with you, that at 16 weeks, it's very difficult to say with surety that everything is normal. So NT scan, which has been done well with the screening, and then an anomaly scan at 18 to actually 19 and 20 is better when we can see the heart more better.
Thank you. Thank you.
Absolutely, I agree. Now with the limit of termination being extended to 24, it's a big breather for us. We call them specifically after 19 weeks or 20 weeks, so that we get that beautiful window up until 21 weeks where we can nicely see the fetus and still have enough time to do if anything is wrong.
Yes.
So, yes,
and in addition, what Chinmay said, that we are looking at everything in all patients. So in diabetes, what are we extra looking at? So it has to be a better screening, a good way of doing your anomaly scan. An echo is extra what we are doing. I think the dating is very important, because if we want to see macrosomia, then we want to have a good dating scan done already. Echo is what is extra. Plus, I think the topic of growth, if you look at the graphs have to be put in. You cannot just look at one value and keep putting different weeks of gestation. They need to be on the graphs that you need to put them on. And Doppler is not very good assessment, especially for a macrosomic fetus. So in macrosomic, as you said, biophysical profile and the CTG is more important than the Dopplers. But yes, Dopplers still need to be done. And it's the growth which is important, which needs to be done every 4 weeks. So maybe Sita, you can add on to what I have said.
Yeah, I agree with you totally. And the other important thing, as she said about diabetic itself, when there is hyperglycemia, the biochemical markers, they get altered. So when you're doing NIPS also, you have to keep in mind with the low fetal fraction, it might alter, it might give you a false positive result. So beware of that. And then a lot of these women are already obese. They have polycystic ovaries in the background, so they are obese. And with the dates being wrong, we often tend to do transvaginal scans in them more often because we can't see transabdominally. So these are all certain issues regarding diabetic women when we see in our day-to-day practice. But overall, yes, from the beginning till the end, they need constant, intense surveillance. And as if it's a combined clinic where they come, they get the ultrasound done, see the obstetrician at the same time, it sort of helps them so that they don't have to keep coming again and again just for all these scans.
So Dr. P.K. Shah, sir, can you
Yes,
comment
sir.
a little bit, because you're the father of fetal medicine in Mumbai. Sir?
Sir?
Whenever I listen to Chinmay, I enjoy.
Yes, sir.
Whenever Chinmay is part of webinar, I always make it a point to listen to her because it's very sweet and short, and the message is very clear from her. And I'm very happy that today's all 3 lectures covered hyperglycemia so beautifully that people who have joined us have definitely got some clear-cut ideas about how to manage this patient in pregnancy and in labor. Thank you, Sneha, for getting these excellent people to your webinar. And now we are waiting for you to conduct the panel.
Thank you, sir. Thank you so much. Thank you, all of you.
Yes,
Yes, Suman.
one small point I would like to make. Putting what Dr. Chinmay said was a very important point. Putting all patients on MNT is okay, but we have to tell them that protein amount should not be restricted, because many times these women are just not eating and we are getting FGRs. So that also has to be weighed, and proper counseling needs to be done for MNT. Not just all restriction, the proteins need to be given in good amount, normal amount, and the other carbohydrates, as Dr. Sushila elaborated, needs to be reduced.
So now we move on to the last leg of our webinar. And thank you, Dr. Chinmay, for enlightening us.
Yes, I would just, sorry to interrupt you, Suman. I would just say one sentence that we do have cases on gestational diabetes mellitus in addition to other medical disorders. So we are going to have a discussion at a stage on the MNT also. So yes, over to you, Suman. Thank you.
I was really appreciating Dr. Chinmay Ratha for her beautiful talk, and really it was very extensive, and I think lots of learning we had. And thank you, chairpersons, Dr. Sita and Dr. Vandana Bansal, for your inputs. And now we move on to the panel discussion, that is HIP. And Dr. Sneha Bihar is the moderator. And for the panelists, we have Dr. K.N. Maleshwari, Dr. Meghna Rao, Dr. Manishwini, Dr. Vasanta Kumari, and Dr. Shilpa SK. So can I have the CVs, please?
No, my introduction is over. You can skip that.
Yeah. So the next. Yeah. So welcome Dr. K.N. Maleshwari to this webinar. She is a consultant gynecologist and obstetrician at Teja Surgical and Maternity Center, Nizambad. She completed her MBBS from King George Hospital, Visakhapatnam. Dr. Malvi held various key positions such as Joint Secretary and Vice President of Indian Medical Association, and also as Vice President of NOGA. She participated in various health camps, community awareness programs, and takes particular interest about issues related to women's health. Next, please. Next, yeah. Dr. Meghna Rao, she is Professor OB-GYN at PIMS, gynec laparoscopic surgeon, Foxy Karimnagar Secretary, She is the 4th TCOG General Secretary. She has her publications in international journal and national journals as well. Presented various papers in international and national conferences. Peer reviewer for various journals. She's been external examiner. Next, please. Dr. Manaswini, she is working in the Pratima Institute of Medical Sciences, and she has worked at Sri Venkateswara Medical College at Tirupati. She has fellowship in Advanced Diploma in ART, Assistant Professor in Department of Obs and Gynae at the same Pratima Institute, and she is also consultant at Star Hospital. And Dr. Vasanta Kumari, she is working as consultant obstetrician and gynecologist at Basanta Jyoti Hospital, Armoor. She has worked as secretary and vice president of Indian Medical Association in the Armoor branch. She has been vice president of NOGA. She conducted and participated in various health camps. And I can't read anything. That is Neha. The things are covered. So, yeah. Can we move that to the next?
It's okay. Only 1 or 2 points. No problem.
I can't read anything. What you have written. Yeah. Dr. Silpa SK, welcome. She is from the Mehboob Nagar OB-GYN Society, and she is presently associate professor in the SVS Medical College. Welcome. And I hand over to Dr. Sneha.
So a very good evening, and I welcome all the panelists here for this panel discussion. As decided earlier, it was by mistake, it is written as HIP, but it is decided to be on all the medical disorders of pregnancy, which are commonly dealt with by the practicing obstetricians and gynecologists. So welcome Dr. K. Malleshwari, Dr. Meghna Rao, Dr. Manaswini, Dr. Vasanta Kumari, and Dr. Shilpa SK. So can we have you here, your videos on, please? Yes. So as all of you know, yes, please put on your video. I will welcome all of you. So friends, as all of you know, pregnancy per se brings about profound changes in the body. And gives you additional load on various systems. On top of that, if the woman has pre-existing comorbidity, medical disorders, it poses the woman at additional risk. So medical disorders of pregnancy, the common ones, anemia, heart disease, hypertensive disorders or HIP, the thyroid dysfunctions, these are the ones which are encountered frequently. But the hepatic disorders, various kinds of infections or febrile illnesses also can pose additional risk of pregnancy. So without much ado, we go on to the first case itself. So Dr. Malleshwari, yes, we have this case for you. Third gravida, para 2, she comes to you with 3 months amenorrhea, complaining of weakness, easy fatigability, breathlessness. She has no pain or bleeding, and her vitals are stable. When you examine, you find her abdomen is soft, non-tender. She has a basic investigation as hemoglobin, which is showing 5g% only. So what is your diagnosis at this point of time, and what other investigations you will advise her, and how do you manage this patient?
Good evening, madam. Thank you very much for this opportunity. And at the outset, I am very much privileged to have the participation in your webinar. And the sessions are very elaborative and very clean and sweet.
Yes, thank you so much, madam.
And the things are very crystal clear. And now the case is, it is a multi-gravida with 3 months amenorrhea. And because she is complaining of weakness and fatigability along with SOB, and her hemoglobin is 5 grams, it is diagnosed as anemia complicating pregnancy. And then we go for
her hemoglobin is 5g%. So what is the severity of the anemia?
Anemia. It is severe anemia.
Yes. And so what investigations you will ask for coming to the diagnosis of anemia and further management?
We'll go for the complete blood picture so that we can see the red cell mass and this hematocrit values, including reticulocyte, and MCV, MCH, and MCHC. where if at all it is associated with B12 deficiency, MCV will be increased.
Yes.
If it is iron deficiency, it is decreased.
Okay. Anything else?
We'll go with the WBC count to see any infections and platelet count.
So on peripheral smear, you will get various information like hemoglobin, hematocrit, and retic count, and also the various red cell indices, the WBC total and differential count, the platelet count. You will also come to know the cell morphology, acid, acid, microcytic hypochromic or macrocytic hypochromic. Yeah. So suppose you have this for this patient, it comes as microcytic hypochromic type of anemia, that is iron deficiency type of anemia. So whether you would, what will be your way of management? And in addition to the peripheral smear, what other investigations you want to do for her?
We'll go for the serum iron profile to see the serum iron and total iron binding capacity, and also serum ferritin.
So when the peripheral smear is showing microcytic hypochromic type of anemia, do you really need to go for serum iron profile? And what is the reason for that?
So that if it is very early stages of anemia or late stages of anemia to present.
Yeah, sometimes you have, clinic, the peripheral smear shows microcytic hypochromic, that is iron deficiency type. But this is a similar picture which is seen in cases of the thalassemias. And that's a very reason where actually you have the hemolysis and iron overload. But the peripheral smear shows iron deficiency type of picture. And that's the reason before giving any injectable iron, you have to rule out that there is no hemoglobinopathies as such. So you have to...
Sickle cell anemia or thalassemia.
Go for, and it is genetic anemia. How will it go ahead with the management? Dr. Manaswini. Dr. Manaswini, do we have Dr. Manaswini here? No? Yes, so Dr. Vasanta Kumari, you can go for this.
Yeah. Good evening, ma'am.
Yes.
Good evening, and thank you for giving me this opportunity. And all sessions are very excellent and very informative. And coming to this case scenario, here she is severely anemic. And to know the cause of anemia, we should know the cause of anemia beforehand. Before treating the patient, we should know the cause of anemia. Whether she is having any severe bleeding axis, bleeding history, bleeding episodes in previous cycles, or and it should be treated accordingly. And symptomatic, she is stable right now. So we can treat it. We can treat her.
But she's symptomatic. She's having excessive easy fatigability, breathlessness.
Yeah.
Yeah.
Excessive fatigue and breathlessness. So it has to be treated as severe anemia, and we should give her. We should advise her for blood transfusions.
Yes.
Immediately.
Okay. Yeah. So for this episode, definitely because of the severity, severe anemia anytime during pregnancy. Especially when the patient is symptomatic, we have to go for blood transfusion. How and when, that we will come to it later. But suppose this patient needs to be, supplemented with iron. Suppose she genuinely has iron deficiency anemia, as we have investigated, and suppose she needs to be given iron in future because she herself has to, her erythropoiesis has to go on, and she should be coping up with her anemia. So, what type of injectable irons you have and you have been using?
Iron sucrose and iron sucrose. Previously, we used iron sucrose, and nowadays we are using iron carboxyl maltose.
Yes, and one more, that is I3. That is the one new guest on in our armamentarium. Okay, so
yes. The dose should be calculated according to her present HB levels.
Yes.
So that formula for iron sucrose levels, that formula should be implicated.
Yes, yes, yes. So rather than going into the theoretical aspect, we will just ask you, does this severe anemia develops all of a sudden? Could this lady been previously detected or diagnosed as having anemia? In other words, whether the clinical manifestations start all of a sudden or the body does give some indication. On investigations, can you diagnose it as various phases of anemia?
Yeah, various stages of anemia. She is suffering with easy fatigability, so she might be in stage 3 anemia, that is in severe anemia. In first stage, there are 3 stages of anemia there, and in the first stage only the laboratory findings were we are able to get that information.
So initially only the iron stores get depleted, and that you can make up by
depleted.
Yes, doing the serum ferritin levels. Yes,
yeah, serum ferritin levels will be low, and same this one total iron binding capacity will get increased.
Yes.
And
then the next phase will be the circulating iron will be less. So naturally the total iron will be less. This percentage saturation will fall. The total iron binding capacity will be increased. So all these parameters will be, it will be altered. Okay. So we can go to the next panelist. What are the effects of this? How does anemia affect pregnancy and pregnancy affect anemia? Yes, who else do we have apart from Dr. Malleshwari and Dr. Vasanta? Do we have Dr. Shilpa?
Yes, ma'am.
Yes, please go ahead.
So anemia affects mothers. This case especially, it is severe anemia. So there is increased chances of her, already she's symptomatic, she can go into heart failure right from first trimester only, early. She's only 3 months of amenorrhea. And there is increased chance of infection for her all throughout. And there is increased chance of preterm, increased chances of preeclampsias. And if it is very severe, uncorrected, it can go to intrauterine death also. And complicated with this, preeclampsia and APH, antepartum hemorrhage, can become much worse for the patient.
Yes,
and during
that is
labor,
because of the abrupt show placenta.
Yes, and during labor, it is another risk of having heart failure, even in first stage, and immediately after delivery of the baby, and even in the third stage. And the complications could be PPH again, and again she can land up with increased morbidity and mortality.
Okay, how pregnancy worsens the anemia?
Yeah,
how pregnancy affects anemia?
Baby is actually a parasite to the mother. So it takes whatever the nutrition is required for its growth. So mother is again pushed further into increasing severity of anemia if it is not supplemented with iron right from the beginning and again added with the diet. So her severity may progress with her pregnancy.
Correct, because already she's anemic, and now on top of that, if she's having this pregnancy, the demands of the growing fetus and her own increased demands will add to the deficit. Also, because she's having nausea, vomiting, her stomach emptying is slow, her digestion is poor. So all these factors will add to her nutritional deficiency or iron deficiency anemia. And of course, later on, she has to prepare herself for labor, delivery, and lactation. So all in all, the anemia will be worsened. We have already discussed these 3 phases of anemia. And of course, now we come to the conclusion that we should have detected this anemia early during pregnancy, or maybe we can say before planning the pregnancy. So Dr. Shilpa, how we can catch these women before pregnancy, or when should we screen them? What is the recommendation or guideline? Hello?
Hello, yes.
Yeah.
So, first visit, everywhere hemoglobin is done. So it has to be done.
Yes.
And it has to be repeated in each trimester.
Yes.
And if it is found to be anemic, it has to be given iron supplementation. The therapeutic dose has to be given.
Yes, so you're correct. In SUG also recommends that all pregnant women should be screened for anemia and treated if necessary. But India, all of you know that its anemia is rampant. The incidence is more than 50%, and that's a very reason every woman should be screened for anemia at its very first antenatal visit. And then it should be repeated at 16 to 20 weeks, 24 to 28 weeks, and 34 to 36 weeks. Ideally, I would say that we should screen all these women just before marriage or immediately after marriage, or when they are planning for pregnancy. So before pregnancy, at least they should be screened and treated so that we prepare them for pregnancy. So very well discussed. We come to the second case now, Dr. Malleshwari. Once again. So you have this, Dr. Malleshwari?
Madam.
Yes.
Yes, madam.
So we have this unregistered primary gravida, married for 2 years. She has come to you with 9 months amenorrhea, mild pain in abdomen, little discharge, fever, cough, and breathlessness. When you examine, you find she's got tachycardia. Rest of the vitals are normal. She doesn't have pallor and pedal edema. She suddenly gets a rupture of membrane, and you find that there is a need to augment her now. So you decide for augmentation, but she lands up into fetal distress, and you decide to take her for cesarean section. When the anesthetist examines her preoperatively, he finds a diastolic murmur there in cardiovascular system, and naturally he labels her as a case of some morbidity. What is the diagnosis? How do you classify this patient, and how will you manage? Of course, the last question will be, could this have been prevented?
This is a case of heart disease complicating pregnancy.
Hello?
This is a case of heart disease complicating pregnancy.
Yes, yes.
And
so undiagnosed till now. So most probably?
It is class 1.
Most probably a rheumatic heart disease. Most probably a rheumatic heart disease. And because it's a diastolic murmur, probably a mitral stenosis. Yes. Okay. So what class? That we come to the diagnosis now. What is the classification?
Because the pregnant lady came up to the 9th month of amenorrhea stage. Mostly is unidentified and asymptomatic, class 1.
But now she's got some symptoms. So most probably she's going towards class 2. Yes, grade 2. Okay. So all of you know this theoretical aspect. So I'm not going to repeat all this. So here usually the ASD, VSDs, PDAs, the cyanotic and the non-cyanotic heart diseases, they fall into this low risk categories. The mitral stenosis 3, 4 and mitral stenosis with atrial fibrillation, AS and uncorrected fallows, they fall into this medium risk category. And of course, the primary pulmonary hypertension, Eisenmengerization, aortic coarctation with valvular involvement, and Marfan syndrome with aortic involvement. All of this, they fall into this high risk category where we actually advise them against pregnancy. So our diagnosis is very clear now: rheumatic heart disease with mitral stenosis, and of course the NYHA grade 2 here. So I would ask Dr. Meghna Rao. Do we have Dr. Meghna here? Okay. So Dr. Shilpa and Dr. Vasanta. Dr. Vasanta, you can take up this question. What are the poor prognostic factors? Yes, Dr. Vasanta.
If she is having in cardiac failure or any history of ischemic ischemic attacks or arrhythmias, and if the ejection fraction is less than 40%,
yes.
Usually the stenotic lesions are more dangerous than that of regurgitant lesions.
Yes.
So the whether it is mitral valve or aortic valve, we should take it into consideration.
Yes.
If it is mitral valve, then the diameter of the mitral valve that should be taken into consideration. If it is less than 2 centimeters square, that is a poor prognostic indicator. If the aortic valve is less than below 1.5, it is a poor prognostic indicator.
Yes.
So all these factors are aggravating factors.
Yes. So Dr. Manaswini, what are the aggravating factors? So we have only Malleshwari, Dr. Vasanta Kumari and Dr. Shilpa, correct?
Yes, madam.
Dr. Manaswini has not joined. Okay. So, madam, you can take up this question. What are the aggravating factors here in this case, as you can see here, and then we go to the next question again. Dr. Shilpa, you can take up this question.
Yes, ma'am. So, any other complications that arise during pregnancy? Pregnancy itself increases the load on her heart, and she can be pushed into heart failure any point in her pregnancy. And complications like anemia, any infections can lead to again heart failure, hypertension, preeclampsia, and labor again, and any increased weight gain, obesity along with it, or multiple pregnancy, or alcohol intake, and labor, and leading to, if pain is not managed during labor, and tocolysis, of course, beta mimetics can lead to increased heart failure in these cardiac complicating pregnancies.
Correct. So, Dr. Vasanta, how does we have already discussed this? How does pregnancy affect the anemia? You can, in short, just say how does pregnancy affect the heart disease, and heart disease affect the pregnancy?
As the pregnancy in states, all the plasma volume will increase by 30%. So the blood volume also increased. So the load on the heart will also get increased. So there are every chance of going to congestive
cardiac failure. Yes.
Yeah, cardiac failure.
Yes.
And there is increased risk for infections also.
Yes.
So
especially the bacterial endocarditis.
Bacterial
Yes.
endocarditis.
And because of this, you have a chance for pulmonary embolism.
Yeah, pulmonary embolism or pulmonary edema. In case of any severe PAH, she may land up in pulmonary edema also. And and she can.
But it doesn't worsen the basic defect. So if she has a stenosis and that particular diameter of the aperture, it will remain the same. Okay. Effects on pregnancy will go a little fast now.
Yeah. And the effect of heart disease on pregnancy means she may land up in preterm labor, and the risk of infection is more, so she may land up in preterm labor, and she may gets into the.
If it is congenital heart disease, maybe anomalies in the baby also has to be checked.
Yeah, almost to the tune of 5%. Yes. So how do you manage this case now, Dr. Shilpa?
Yes.
To avoid all this complication, if at all you have a diagnosed case of heart disease, how do you manage? What factors you will be avoiding, and what will be your prophylaxis for this patient?
Yes, first and foremost, clinical examination. We should never miss out on examination of the patient, especially when they come first time. And then if we have detected any cardiac disease, the actual lesion has to be detected and 2D echo has to be done for her. And it should be a team work with the cardiologist. That would be better in a tertiary care center, especially if she's a symptomatic one with a grade 3 or 4. And preventive aspects should be anemia at all costs should be prevented, and infection should be prevented. Preeclampsia, if it develops, it has to be managed by admitting her to the hospital, and careful fetal surveillance has to be done. If it is congenital heart disease, then the congenital anomaly in the baby has to be detected with proper anomaly scan and the fetal 2D echo.
Yes.
And the heart, whenever she's prone to develop cardiac failures at 32 weeks and during labor, it has to be managed with multidisciplinary.
Yes, perfect. That should be the message. It has to be managed by a multidisciplinary team, and it has to be a team approach, always not an individual management. So with this, we go to the next case now. We have this for the antenatal checkup, 10 weeks of gestation. On examination, she is 152 centimeter tall, weight is 69, so BMI is 30 kilometer per meter square, 30 kilogram per meter square, and she does not have a family history of diabetes. Dr. Malleshwari, the question, I would just like to request to go fast over this because this is very important. I want you to revise this.
Can I
Hello.
take this, madam?
There's some connecting.
Hello.
Yes, Dr. Shilpa, we can hear you.
Hello.
Yes, we can hear you.
Okay, we should screen the person.
Yeah, actually,
because
some
her
network
BMI
issue, I got disconnected. Yeah. So, can you see my slides?
Yes, ma'am. Yes, ma'am. Because her BMI is more than 30, she should be screened for diabetes so that we can avoid the further complications by avoiding
Yes.
with Dipsy. 75-gram glucose with 2-hour glucose test so that we can see that whether she is diabetic or not. And we have to rule out the other chances for because her age is 30 and BMI is more than 30. We should go for GTT with 75 grams of glucose. Am I audible?
Yeah, you are audible.
Hello. Yes, so just go ahead quickly. Whether only this BMI high, age about 35, the women with family history of diabetes and PCOS women, only this should be screened, or we should screen.
It is a
Yes.
universal screening
Okay.
process in pregnancy.
Yes. So because it has got effect on the baby as well. So all the organization, as we have discussed, FOXI, FIGO, Government of India, Ministry of Health, Family and Health, all of them unanimously,
If we detect, we
they
can teach
agree.
the
Yes.
person early
Yeah.
to confirm the baby malformations and everything.
Correct. So at 10 weeks, so we don't have Dr. Meghna. So you also can continue with this. Should we use HbA1c for screening of GDM during pregnancy? Does it correlate well with the blood glucose level?
Family history.
Yes. For GDM.
For GDM, not needed.
Does it correlate with the blood glucose levels, or it tells you only about the management of diabetes? What is the relation of HbA1c with the congenital malformations?
Detects the hyperglycemia for the past 3 months.
Correct.
And
So it tells you how good the control is, how good or bad the control is.
If it is more than 8, it will be around 7% of malformations. And if it is in between 8 and 10, 19% of malformations will be more, and more than 10, 30%. Almost 1/3 of the babies will be with malformations. So we should be detecting HbA1c.
Yeah. So if the patient has HbA1c of more than 10, definitely you have to warn her. You have to explain her the very high possibility of congenital malformation, and maybe you can just help her in making the decision whether she should go for termination of pregnancy. But you will not force her for termination of pregnancy. You can take an informed written consent that you have explained her and leave the decision to her. So how well the blood sugar correlates with the perinatal mortality? That was another question. So here we have the blood sugar levels of more than 200, almost 35% of perinatal mortality. Between 150 to 200, 16% of perinatal mortality, and between 100 to 150 it is 8%, and around 100 it is 4%. So we have to, these figures, they bring out pregnancy, and they should be told about the target levels of blood sugar. So before breakfast, it should be 69 to 90. Before lunch and dinner, it should be between 60 and 105. And post meal, it should be only 120. So we have already agreed on this point that it should be universal screening, that is every woman during every pregnancy. And you have heard a lot about this screening, but still I would just ask somebody to say it out once again, that how should you go for the screening? Single step 75-gram glucose. Yes, Dr. Shilpa, you can take up this.
DIPSI guidelines says we have to universally screen all the pregnant women in India.
Yes.
We should screen all the pregnant women universally at the first visit. We do it.
Yes.
They can come fasting or no fasting. We have to give them 75 grams of glucose and then check the glucose levels after 2 hours. And if it is more than 140, we label them as GDM. So if it is normal at the first visit, then we have to do it again at 24 to 28 weeks. If it is normal, then do it again at 32 weeks.
Okay.
If it is more than 140, we label her and treat.
Yes. So this is just an algorithm in short, that every woman who comes to you for the first antenatal visit, you have to go for single step 75-gram glucose challenge test. And if, as you rightly said, if the obesity comes 140 mg%, the levels of blood sugar after 2 hours of the glucose load comes more than 140, you label her as GDM and manage accordingly. If it is normal, you repeat it at 24 to 28 weeks. And of course, you anytime it goes above 140 mg%, you have to label her as GDM and manage accordingly. So the patient whom you label as GDM, first and foremost, you give her 2 weeks time, you explain her what MNT is, and then after 2 weeks, you have to repeat her blood sugar level, that is 2 hours postprandial. If that is more than 120 mg%, then that is a time where you have to start with the medication. Now, any scope for prevention, we will not go for this. This is what I have just discussed, Dr. Vasanta, for you. But suppose this lady has got, after 2 weeks of MNT, her blood sugar level 2 hours postprandial is more than 120. How do you go ahead with this patient now? Dr. Vasanta.
Yeah, ma'am. Apart from MNT, you should add a medication to that treatment. Medication.
So what medication?
Yeah, medications in the form of metformin, oral hypoglycemic agents, or insulin. We can use insulin also, depending on the trimester of the pregnancy. Yeah.
Yeah. So before going to the medication, I would just want to discuss you in details about the medical nutrition therapy. How do you decide the calorie counting? How do you decide the spread? Can you just let me know?
This calorie intake should be measured as depending on their physical activity. So if the patient is in
Is it only physical activity, or is it the pre-pregnancy weight and BMI?
BMI.
Yeah, pre-pregnancy weight and BMI and the physical activity right now. That both should be added, both should be taken into consideration.
Both these factors should be taken into consideration. Okay, so the calorie counting is done by knowing the BMI or the pre-pregnancy weight, and then the level of activity, whether sedentary or moderate or the heavy work she has. And otherwise, as a routine, you allow 350 calories extra, but considering this, the caloric requirement varies. This is as far as the calorie recommendation, the calorie count is concerned. How do you make the spread of these calories? What do you feel that how should be her dish? How do you allow the patient to have the dish?
Yeah, in the form of
how much percentage of protein,
40,
fats and carbohydrates?
Yeah, 40%, 40 to 50% it should be from carbohydrates, and 20% from the
Otherwise, for non-pregnant or non-GDM patient, we allow almost 60% of carbs. 50 to 60%.
Yeah, 60% of the carbs. Yeah, and remaining the 30 to 40% from fats. It should be.
Okay.
Yeah.
Okay. So coming to the proteins, the most important is protein. Yes, not to forget that. So what medication? We come to that first. What medication? Whether metformin or insulin, how do you decide that?
Yeah, metformin should be given as the first line of treatment. preconceptionally also, as previous talks are there. Metformin also we can consider it as preconceptionally also, and in the first trimester you should switch over to the insulin, and after second and third trimester you should give metformin.
Do you all agree with Dr. Basanta, or is there any difference of opinion? Evidence says that insulin is the first line of treatment and it should be considered first. But let us see what this Indian scenario says, that management should be in accordance with the available national resources, and not even if they are not fulfilling the specific diagnostic and treatment protocols. Something is better than nothing. So we have to think of the infrastructure which is required, and if at all at remote places, whether the facilities for testing the blood glucose levels, whether the facilities for explaining all this procedure, also the symptoms and signs of hypoglycemia, all of this, where it is not available, these are the women for whom you can go for metformin. Of course, you have heard during the talk that metformin is the culprit which can lead to the fetal growth restriction also. So that you have to keep it in mind. So given a choice, insulin should be the first drug of choice. Here, this is evidence also. Metformin or insulin therapy is the accepted medical management of pregnant women with GDM, not controlled on MNT, but insulin is the first drug of choice, and metformin can be considered after 20 weeks of gestation for medical management of GDM. So,
Madam, I have a question, madam.
Yes, yes, please.
If a lady is already PCOS and she already is on metformin, can we continue metformin in first trimester?
In fact, this is there in some of the slides. If the lady who is on treatment for PCOS, who is on metformin already, we need not discontinue it. We can continue it, but you should not start metformin as a fresh during first trimester. That is what the guideline says. Okay. So coming to the next case, Dr. Malleshwari, this is a patient for you, 36-year-old lady, second gravida with previous one cesarean section. Now she has 26 weeks of pregnancy, diagnosed diabetic during third month, and she's on insulin. Her HbA1c is 6.5, her blood pressure is 150/90 millimeter of mercury. Clinically appears small for gestational age. So what all risk factors she has? How do you manage these patients? The maternal and fetal monitoring and the treatment.
This is definitely a risk case with post-seizure and elderly gravida with second trimester case, and diabetic on insulin with
and one more risk factors you have.
And PAH.
Yes.
And already
small for gestational age,
along with HbA1c more than 6.5. So she has more than 5 risk factors.
Yeah. So what investigations for the mother, for the baby?
As she is in the 26 weeks of this thing, we have to go for the.
So what should have been done by the obstetrician? You can talk of
because she is a diabetic mother. From the beginning on insulin, we should go for the biochemical markers along with the NT scan, and then we can plan for uterine artery Doppler along with the NT scan for PI. If it is more than 0.58, we should consider for the treatment of low dose aspirin. We should go for the target scan to rule out the cardiac anomalies associated with diabetic mother.
Yes, there's something called as SDP gestosis score, where you have the maternal characteristics to be taken into consideration. So if the patient has family history of hypertension or any type of hypertension she herself has, then if she has diabetes and if she has thyroid dysfunction, the risk factor directly goes to 3, and that is an indication to start the aspirin, low dose aspirin, as soon as possible, as early as possible during pregnancy. Okay, so how will you monitor this woman? She's already on insulin. So how do you monitor the insulin therapy for her?
By seeing the early hours of fasting blood sugar, post-lunch sugar, and before the sleep, minimum
So how much it should be?
6 points minimum. Minimum 6 times blood sugar should be monitored.
Okay, that is initially till you stabilize the woman.
Once it is
Otherwise, once you
minimum
stabilize
twice.
her on insulin, how frequently you should?
Minimum twice.
Yes.
Before,
So one
before
fasting
breakfast
and
before dinner.
one each post meal for both the meals.
Before they go, yes.
Yeah. Okay. How should it be? What should be the levels for this lady?
Whenever we look for it, we should go for fasting blood sugar less than 95 and post lunch should be less than 120. That is the target.
Post meal, whether it is lunch or dinner, it should be less
Post
than 120. So basically, when you are putting the patient newly on insulin, it should be a 7-point testing or 6-point testing, whatever you are accustomed to. But then that you have to see that and basically you have to start from the lower dose depending upon her sugar level. So if her sugar level is between 120 to 160, you have to start with 4 units. If it is 160 to 200, you have to start with 6 units. If it is more than 200, then you have to start with 8 units. And then you have to monitor the fasting, and then the 6-point testing you have to go for. Once you stabilize this woman on that particular units of insulin, then you can maybe repeat every daily initially and maybe every third day once she's well stabilized on this insulin. So fasting should be less than 95, right? And 2 hours should be 2 hours postprandial should be less than 120. That is what the requirement is. Suppose any time her fasting blood sugar level goes more than 95, then how do you titrate the insulin dosage?
If fasting is more, we have to add dose to the night dose.
Yes. So how much you will add? Suppose
by 2 units. 2 units.
2 units, correct. And suppose you have the 2 hours postprandial more than 120, then how many doses and where do you add that?
If it is more, we should give the dinner morning dose.
Yes,
Morning
before breakfast, when you give it at the time of breakfast, the 2 units of insulin should be increased. So you have to monitor it every third day till the dose of insulin is adjusted and she is stabilized. If once you stabilize her on fasting blood sugar less than 95, post meal for both the meals less than 120, then you have to continue the same dose of insulin as well as the MNT, the nutrition therapy and the physical exercise, what you have advised her. Continue the same dose, MNT, physical exercise till the at least till the salvageability and maturity of the fetus is achieved or till no other complications happen. So that comes to almost 39 to 40 weeks of pregnancy if nothing goes wrong. So meanwhile, you have to monitor the woman by various parameters, her weight gain and the sugar levels we are talking about, HbA1c as well. And the fetus, you have to go for the ultrasonography, serial cephalometry, the biophysical, the Mannings and modified Mannings, the NST. And once you find that then how do you decide? Suppose you have taken this pregnancy to 37 weeks. Now, how do you decide? Dr. Vasanta, you can take up this question. How do you decide when to deliver her?
She is an insulin. She is an insulin, so we can decide by 38 weeks. 37 to 38 weeks, we can decide after getting the line maturity.
Yes. So if nothing goes wrong, we can wait till 38 weeks at least, 38 to
at least.
What is the point where you want to terminate her? Whether you want to intervene somewhere or you just allow her to go into spontaneous labor?
Spontaneous labor, depending on her BP is also high, 150 to it should be monitored, 150/90 like that.
Yeah.
So it should be monitored, and the growth of the baby should also.
So for blood pressure also, you have to send various biochemical investigation as we are talking about that. And we don't have to concentrate on the diabetes only. You have to think about the HDP as well. So the liver function, the kidney function, all this, the coagulation profile, everything has to be done. The fetal monitoring for growth and well-being has to be done. Of course, if here we already have this growth restricted fetus, that is why the question was that whether you would like to continue or pull on this pregnancy. So already when the fetus is having growth restriction, if that we have to be really have close monitoring
Close
of
monitoring.
well-being.
Close monitoring is
Yes, anytime beyond 34 weeks, you just keep the baby ready with antenatal steroids, and maybe if at all you feel that there may be a necessity for premature intervention, you can give prophylactic Maxil for the neuroprotection of the baby. So deliver only if there is fetal jeopardy, that is for the fetal indication. But suppose if everything is fine, things go well, not in this pregnancy. We have talked about this, that there is a fetal growth restriction. So you have to intervene when there are interference, when the fetal jeopardy takes place. That's all. Otherwise, the mother is well stabilized. But suppose otherwise, if the mother is well stabilized on insulin, even the growth is going well, and there are no problems whatsoever. If the fetal weight is less than 3.8 kg, we say it is not a macrosomic baby. The patient's control is not so good. It is, fluctuating glucose levels, or maybe the lady is not compliant with the diet or insulin. And in this situation, maybe we have to terminate a little early. And so that is the time you have to intervene. If everything is fine, she's compliant and things are going well, you may wait till term and allow her to go into spontaneous labor. Between 3.8 to 4 kg, maybe around 38 to 39 weeks, we would like to induce her to see whether she can deliver vaginally. Of course, for any obstetric indication, we may have to go for cesarean section. But if the baby weight is more 4 kg, we have to decide for elective cesarean section. That is what the message here is. Suppose this patient want to allow her to go into labor, and whether you want to induce her, and how do you monitor her labor. Dr. Sushila Rani has covered it very well. You can just talk about what all things you need to monitor.
Yeah, if she is already she is in previous section, this is a case of previous section. So we have to see the indication for the previous section.
Yeah, for this patient, we have done with the discussion. We're just talking in general now. For this patient, we have said previous cesarean section, fetal restriction. If there is fetal jeopardy, anytime that is a point of intervention. So we have to go for cesarean section. But otherwise, if everything is fine, there is no obstetric indication for cesarean section, and you have this well-controlled, stabilized mother and baby, and you now allow her to go into labor. So how will you monitor the labor? What things you will keep a watch on?
First of all, labor is a
strenuous process. Dr. Shilpa will take up. Yeah.
Yes. So there is no contraindication for induction of labor in GDM, well-controlled, average size baby with good pelvis. So it is generally done early in the morning, we start with. And for just induction, she has to take her normal diet in the morning and morning insulin. And once she's in, and the first stage of labor, we monitor by partogram, giving good analgesia, giving, and then hourly, her glucose levels has to be monitored. And it has to be maintained between 70 to 110. If it is more than 120, then only we start with the DNS and insulin infusions.
Yes.
And a cesarean indication is only obstetric indication. Then hourly only it has to be monitored. And this 6 hours prior to delivery, maintenance of the blood sugar levels in the mother will determine the neonatal hypoglycemia. So if it is maintained in a normal level, then we will prevent this neonatal hypoglycemia.
Yes. Otherwise, very well discussed. Only thing is her hydration has to be maintained very well, because dehydration itself can predispose her to ketoacidosis. So her hydration needs to be maintained, and her glucose levels are to be monitored hourly, as you said very rightly. It has to be kept between 70 to 105, as we have said. Anytime it fluctuates, then we need to add insulin to the drip So here, when the blood sugar levels are between 90 to 120,
no
I mean,
insulin.
even then you don't need the insulin. 120 to 140, you need to start with 4 units. 140 to 180, you start 6 units, and more than 180, you add 8 units to the infusion. Of course, what we don't have to forget is the postnatal part. Because we all the obstetrician, what we do is we deliver the lady and we forget about the post delivery workup and the advice. So postnatal advice is very, very important. That, as Dr. Sushila Rani has also said, that the woman who develops GDM is to be considered as a pre-diabetic, and we want to avoid the diabetic population to increase. So we have to focus on the diet advice. What we have started her on MNT, we have to warn her that she has to continue this even after this, because another 5 years down the line, maybe she may develop the over diabetes. And that's a very reason: diet, exercise, optimizing her weight, BMI, and of course the contraception, which is not adding fuel to the fire. The GCT, as we said, 24 hours later, a week later, 6 weeks later, and monthly thereafter should be done. She has to continue her breastfeeding, very important, because breastfeeding helps her to utilize at least 500 calories per day. 6 months, she can, that will help her in reducing her weight as well as utilize her calories and optimizing her blood sugar levels. So it is very high. It is highest between 6 months to 5 years, plateaus thereafter, that is 10 years, almost 30% in first 5 to 10 years, or around 50% in the first 25 years. So we have to keep a watch on all this. And contraception, if at all, Dr. Malleshwari, you can talk about, that will be great. Which contraceptive? The medical eligibility
Mainly
criteria.
Copper
Yes.
tea is better. With restriction, copper tea is mostly preferable because oral contraceptives are not advised, which increases thromboembolic manifestations. Even progesterone only pill is also relatively less to accept. And even DMPA,
yes,
all the progesterone pills are progesterone inducing agents are prone to thromboembolic manifestations. So IUCD is always better, especially copper.
Yes, a strict, correct, very well said. A strict no to the combined oral contraceptives. Yes, oral progesterone only pill or injectable may be a little acceptable, but intrauterine contraceptive device, that is copper T device, is the most preferred contraceptive. So just to come to the conclusion, that what is the standard of medical care in diabetes 2020, insulin is the preferred treatment for GDM. Metformin should not be used as first line agent as it crosses the placenta to an barrier. Metformin, when used to treat PCOS and induce ovulation, should be discontinued by the end of first trimester. So with this, I conclude my panel discussion, and once again, I, with folded hands, request all of you to support me wholeheartedly for my candidature as Vice President Foxy from West Zone. Here you have 2 posts from West Zone. So please support and vote for me. Your every vote is precious for me. So once again, I thank all of you. And even though we had less panelists, I'm very happy. The panelists were very interactive, and the excellent inputs from all of you have definitely added knowledge. I'm sure the attendees would have been benefited. Thank you so much. Over to you, Lakshmi. And I don't know whether sir is there to have his expert comment. Do we have?
Sir is
do we
here.
have? Sir is here.
Yeah.
Yeah.
Yes, sir. Sir, can we have some comments, expert comments from you, sir?
I think midweek It was an academic feast that we had hyperglycemia and pregnancy. We had anemia, heart disease. What more do you want, I think? All the topics were very well covered. Thank you very much for having me with you, and wish you all the very best and success for your vice president's election. Thank you.
Thank you so much, sir. Thank you so much, sir. It is so inspiring you say being here till the end of the program. Thank you so much. From my side, I express my gratitude to all the presidents and secretaries of Nizambad, Nalgonda, Karimnagar, and Mehboob Nagar. And I thank especially Dr. Chinmayi Radha, who helped me in organizing and coordinating this program. I thank Dr. Lakshmi Chirumamela for the excellent coordination. And thanks, Dr. Suman, for being the excellent MOC for today's program. Thank you so much. The pharma partner, Bhavna Verma from the Core Connect. Thank you, all the esteemed faculties and panelist chairperson. Thank you, everyone. Thank you so much for blessing me.
Yeah, Madam PK Sir, Dr. Chinmayi Radha for taking me in.
Yes, sir. Yes, Suman. You can.